Good evening, friends. Good evening, senior faculty, practicing surgeons, and young residents. I'm sure today you're going to have a feast of galaxy of national faculty of international eminence going to share their experience in handling the difficult part of the bariatric operations. Friends, IAGES Primetime is a fortnightly which has been curated by the senior leaders of IAGES to bring the special talents of lifelong wisdom which has been acquired by eminent experts in and out of country to give you the best of the knowledge, best of the wisdom for the benefit of the practicing surgeons and the youngsters. May I now have the honor of inviting our president, Professor Sunil D. Papat. Professor Sunil is known to all the surgical fraternity of minimally invasive surgery, this part of the country. And I'm sure we have participants from more than 6 countries, the associated institutions of friendly institutions of IAGES. As a customary word, it is my responsibility to introduce our president. Professor Sunil Papat is the chairman and head of the surgical gastroenterology at the Nidhi Hospital, Ahmedabad. He has been very much active academics since the last 20 years into IAGES at various levels of IAGES, from the member to the president. He has held up all the important positions year over year, and he has ascended carefully as of the IAGES. Friends, it has been a pleasure to have the leadership qualities of Dr. Sunil Papat guiding us to do program after program. And he has special interest in foregut surgery and endotherapy. And he has been an eminent surgeon doing advanced endoscopy and advanced laparoscopic procedures also. So, ladies and gentlemen, may I have the honor of inviting our president, Professor Sunil Papat, to welcome the faculty and welcome the program. Over to you, sir.
Thank you, Dr. Agarwal. Good evening, friends, respected faculties. I am very pleased and honored to welcome you all to this yet again exciting episode of IAGES Primetime. IAGES Primetime has made its space on digital platform over last 1 year, and now we are clocking more than 2,500 of audience every time we are having a primetime program. IAGES is a 28-year-old organization which is the largest of laparoscopic surgeons in India, the most vibrant organization. And because of the wisdom of its forefathers and founding members, we are seeing the fruits today of excellent scientific and fellowship activities. We lost 6 months because of the COVID pandemic second wave this year. However, in spite of that, we have been successful in doing more than 10 online programs, and now one by one we have started FIAGES, endoscope FIAGES. We already completed false upper GI in Delhi, very well organized by our dear friend Dr. Randeep Wadhawan. And we have upcoming programs like Lab Colli Skill Course in Jaipur, FIAGES in Goa. Then we have false bariatric in Kolkata, false hernia in Kanyakumari. Then we have false robotics in Delhi, and FAGI, that is advanced endoscopy course in Guwahati. Just last week, our dear friend Dr. Agarwal organized a combo event in Chennai, FIAGES and EFIAGES, which was very successful with more than 200 delegates, and it added more than 100 new members to IAGES. We are going back again to Chennai next month, this month only, to false colorectal organized by Dr. Pravin Raj. Friends, obesity, all of us are into the treatment of obesity in one or the other way. But obesity surgery has made great inroads over the last 2 decades in India. Today, we are blessed to have the most exciting bariatric surgeons of India giving their presentations. There are plenty of bariatric surgeries, procedures, and endoscopies happening. And it is of utmost importance for all of us to know and be aware of various complications which can happen of variety of procedures. I welcome all the faculties, all the leading bariatric surgeons, and we have the pleasure of having President of Obesity Society of India, Dr. Manish Khaitan, among us as a moderator. I'm sure this program will break all the previous records, and this will be a once in a lifetime program for all of us. Friends, all these programs are telecast live on DocPlexus, on Facebook Live, on YouTube channel, and they will be available later on IAGES YouTube channel for further viewing. Thank you very much for being here, all my dear faculties. I once again welcome you all to this platform. Over to Dr. Kanagwal.
Thank you, President. I'm sure we will update to all the standards which are setting at high bar for the academics for the IAGES. I'm sure back-to-back academics is waiting for academic feast is awaited by all the students and the younger colleagues. Ladies and gentlemen, now we move to the business of this evening. We have the talks from eminent faculty who have been having their lifetime dedicated for this specialization of bariatric operations, for which we have the honor of having the first moderator being none other than Dr. Praveen Raj, who himself has been a very eminent bariatric surgeon who has had original textbooks being published. People start publishing the articles. He has moved to have his own monogram of various areas of bariatric surgery compiled, and it is now revered as a very important textbook across the globe. To his feather and feather of the cap, he has had his MBBS, MS, and later he did his DNB in surgical gastroenterology, and he has obtained PhD in bariatric surgery. To add more further, he has got trained at multiple centers in Australia, Weill Cornell, New York, and his annual program on laparoscopy has been a very astounding success. The mere fact he has been present in OSSI, AMASI, and IAGES shows the dedication and the commitment to the profession of bariatric surgery. May I have the honor of inviting Dr. Praveen Raj to moderate the first session. Over to you, Dr. Praveen.
Thank you, Dr. Kanagwal, for the wonderful introduction. And I think I would like to thank IAGES for this wonderful prime time and the different academic initiatives done on a regular basis. And I think Dr. Kanagwal, yourself have been doing a great job with this regard. And at the leadership of IAGES with the President, Dr. Sunil Poppet, doing a great job. And I think it's a pleasure and privilege to be part of this wonderful session on bariatric surgery, focused on the complications as such. It gives me immense pleasure to introduce to you Professor Sandeep Agarwal, I think who's the well-known bariatric surgeon in the country from the prestigious Institute of AIIMS, and who also is a surgeon, who's also the surgeon who did the first robotic gastric bypass in the country, and who has some of the largest number of publications in the country in different aspects, not just from the surgical aspect, but from the science behind bariatric surgery. And with this regard, I think we have worked together so well for a long period of time. And I think none other than Sandeep Agarwal would be the right surgeon to talk to you on general bariatric surgery. However, for the topic for today, which is the complications of sleeve gastrectomy, and I think it's wonderful to see Dr. Sandeep after a long time. I think COVID has kept us away for long, and I think good to see you. And I'm sure you'll do great just for your talk. Welcome, Dr. Sandeep. Over to you, and looking forward for your lecture.
Yeah, good evening, everyone, dear friends and colleagues. And thanks, Praveen, for the introduction. And also like to thank Dr. Sunil Popat and Dr. Kanagwal for this opportunity to be talking on a very important topic, which is really important in bariatric surgery because sleeve is one of the commonest procedures. So I'll just be sharing my screen. And so can you see my screen?
Yes, sir. We are able to see your screen, sir.
Okay. Great. So I bring greetings from AIIMS, and So again, as I said, the topic is an important one. Sleeve gastrectomy being one of the most common procedures. 60% of all the bariatric procedures across the globe are sleeve gastrectomy. And despite a lot of initial issues and myths about sleeve, it has come of age and has become a very standard procedure and evolved in technique over the last 10 years to be a fairly safe procedure. I must say that. There's no conflict of interest as far as this talk is concerned. If you look at the complications of sleeve or any other bariatric procedure, as such, the leak is probably the most dangerous complications, may not be the most common. Bleeding, stricture and other issues leading to food intolerance, and in the long term, gastroesophageal reflux and Barrett's. And there are other complications, but I'll focus on these 4 because the time is short, limited. So we talk about sleeve falling sleeve gastrectomy. As I said, is the most feared complication. The overall reported leak rate globally varies from 0.7, average being 2.5%, but over the years it has reduced to roughly between 1 to 2%, less over the last decade. And in a paper by Dr. Michel Garnier, he showed that leak rate is decreasing, roughly in 46,000 cases, showed roughly about 1.1%. Why is it important? Because leak leads to abdominal sepsis, multi-organ failure, prolonged admission, chronic gastric fistula, and a lot of morbidity and some mortality. And this requires multiple interventions, whether endoscopic or operative or radiologic. And it's a real trauma both to the patient as well as surgeon. And mortality has been reported up to 3.3%. If you look at the diagnosis of sleeve, it's basically clinical as in all other areas of surgery. But there are laboratory parameters which can help, like brain fold amylase or C-reactive protein. Imaging is required in most cases, and sometimes we may have to resort to re-laparoscopy. We are all aware of the clinical features: fever, more than 100 degrees Fahrenheit, tachycardia, more than 100 per minute, abdominal pain, left shoulder pain, tachypnea, patient not looking well. I think it's probably one of the most, important thing. If you go on a round, every day one should exclude a leak, looking at the patient and other parameters. And obviously symptoms, it's been reported at the time of leak. In an early leak, tachycardia is probably the most important symptom, and for the late leak, fever is the most important symptom. In this series, by 16 leaks, fever was found to be the most important symptom, as most of the leaks present late. So the diagnosis is, you have to have a low threshold. The essential symptom may be delayed, and hence high index of suspicion is absolutely mandatory. Don't rely on the drains. Drains are usually used, including us. We still use it, but they have a low sensitivity to identify the leak. And a drain fluid amylase, however, may have a high predictive value. But the most important, probably, laboratory parameter used nowadays is C-reactive protein more than 150 milligram is an indicator of a complication. Imaging, as I said, is frequently used. However, upper GI series, has a poor predictive value, and a negative study does not rule out a leak. First investigation choice is CCT, oral and IV, and one can have an additional on-table gulp of oral contrast, and has been reported to have a detection rate of leak of 75%. Sometimes fluoroscopy may be used, a gastrointestinal fluoroscopy may be used in combination, and patient may be asked to lie down the right lateral, that means the left side down, and it can increase your detection rate of leaks. In our own experience, CT scan and upper GI study are complementary, if other may help, and vice versa. So, as I said, repeat the study in the right lateral position in the supine position. These are some of the images showing, leak, a controlled leak coming to the drain. Again, a small contained leak in the upper part of the sleeve. So, these things can help. Again, here, a collection in the perigastric and the perisplenic region. So, how do you manage leak once you diagnose it? It depends on first factor is the severity of the hemodynamic stability. Then is the time of appearance and then the location. So, if you look at if the patient has frank peritonitis or hemodynamic instability, which is uncommon because most of the leaks are small. In our own experience, we hardly have a patient who will present with frank peritonitis. Obviously, once it's there, you have to resort to prompt laparoscopy or a laparotomy, and the prime intervention is the drainage with generous lavage, a feeding jejunostomy, and some sort of, or depending on the time of surgery. Now the time becomes crucial. So if you are within 72 hours of surgery, then a primary closure may be attempted along with omental reinforcement, or a serosal patch, or a T-tube or Foley's gastrostomy. However, if you have more than 72 to 96 hours, no attempt should be made to repair this defect because it increases in size. It makes the things worse. So drainage and lavage alone will help here. If the patient is hemodynamically stable, again, within 72 hours, one can resort to laparoscopic drainage and feeding jejunostomy because that's the time you can close the defect. But if it is more than 72 hours, which is usually the case in most worst cases, one can easily manage the patient with conservative approach. And what is a conservative approach? It includes IV antibiotics, which is broad spectrum, image-guided catheter drainage, which is, if you have a skilled radiologist, it's probably one of the best ways to drain a localized collection. Then nasogeneral feeding, which can be done in the next 2-3 days. They may not be done immediately on the diagnosis of leak. And proton pump inhibitors. Again, IV antibiotics may be required for prolonged periods. So this is our standard approach for management of a leak, which presents after 72 hours. If you look at these images, this is a patient with a small leak with a perisplenic collection, managed with nasojejunal feeding, didn't require a drainage, but it was a controlled leak. And after 3 to 4 weeks, the contrast was going down the G junction without any leak. So again, we have about 6 to 7 cases like that with successful outcome. What are the intervention for persistent leaks? And I will talk about endoscopic options in brief because they become popular. And then there are the surgical options. So what are the endoscopic options? One of the commonest intervention used nowadays is the self-expanding metallic stents and the plastic stents. And some people, if the defect is small, one can use clips. As in this, clip, we have tried using clip in this patient where the defect was small but did not succeed. And so the success of clips depends on the size of the defect. Then you have tissue sealants, suturing systems, and the internal drainage techniques. The basic principles are you drain the collection either radiologically, surgically, or endoscopically. Then, considering the various aspects of the leak, the defect size, the margins, the viability, one can determine the appropriate endoscopic approach. So, what are the principles of endoscopic management? Treat the distal obstruction with balloon dilated or luminous stents, because obstruction is a common, cause of leak, a distal obstruction. Remove foreign bodies from the leak site and intervene early. That's what the endoscopy says. Although from our own experience, we have not required endoscopic interventions, and whenever we have tried, we failed actually. So maybe you need a really expert bariatric endoscopist to do these things. And what are the endoscopic techniques? The closure techniques, the covering techniques, and the drainage techniques. The closure techniques includes clips, as I showed, endoscopic sutures, and the endoscopic, sutures. The covering techniques include stents, the tissue sealants, and the drainage techniques which are used, in chronic fistulas, where endoscopic vacuum therapy, pigtail, septotomy, and balloon dilatation. I won't go into the details of these approaches. We don't have any practical experience, but nowadays, stents are basically used early. If you are planning to use a stent, use it early, in an early leak, less than 45 days, because more than, after 4 to 6 weeks, the tracts gets epithelialized and stents may not work. And use a stent which is designed for sleeve, like a mega stent, which has a decreased chance of slippage. So this is an interesting review of endoscopic management leaks and fistula with bariatric surgery published in Surgical Endoscopy about a couple of years back, which said about 37 studies with about 3 of sleeve, sort of a data, which said self-expanding stents are useful for large leaks and fistulas. Usual duration is 6 to 8 weeks, and the healing rate is roughly about 92%. However, if you look at the migration rate, it's about roughly 23%, like 1 in 4, which is fairly high. This series said clipping is useful for fistulas less than 2 centimeters, and fibrin glue is effective for thin and clean fistulas. Of course, there are lots of fine print, lots of things in the fine print, but this is the overall message from this systematic review. What about chronic fistulas, the leaks which become chronic? Again, the stents are not useful. That's been clearly shown. The clips and suturing show good images. Treatment of choice is endoscopic internal drainage, either the pigtail, endoscopic vacuum therapy, septotomy, and drainage. These are, this is the pigtail drain which is put through a nasocavitary, nasal route endoscopically. And a septotomy is basically removing the septum using a needle knife to create a common cavity where you can wash the abscess cavity and irrigate it and put a catheter to drain. This is a summary of this, endoscopic management where early leaks are managed by stents or clips depending on the size, and the late leaks of the fistula are managed by septotomy, balloon dilatation, or internal drainage with EVT. Now coming to bleeding. Now bleeding, if you look at roughly the rate is again 1 to 2%. I think with the more emphasis should be placed on prevention of this complication, because leaks have decreased with careful attention to a lot of things, but bleeding is still a problem. And roughly the rate is between 1 to 2%. If last series it was shown to be 1.6%. So where does the bleeding occur from? The staple line, the omentum, the short gastric vessels, the port side, or due to anticoagulation itself. And we are all aware how it presents: tachycardia, hypotension, excessive drainage, increasing pallor, and abdominal pain. Don't look at the drain. Don't depend on the drain. Drain may get blocked. I think the single most important factor is hypotension or abdomen. Abdomen can hide liters of blood without showing any other sign except hypotension. So once the hypotension is there, please rule out bleeding as a cause. Management is conservative in most of the cases. Resuscitation, stop the anticoagulation and do a serial hematocrit and close monitoring, arrange and transfuse the blood. And re-laparoscopy is required, especially if you have early bleeding on the day of surgery, or the drain output is high, or the patient has persistent, hypotension, which is really having a recurrent hypotension. One episode of hypotension, you transfuse blood, patient becomes stable, it's all right. But if the patient has again an hypotension, please rush to OT and re-laparoscope. There have been predictors in a recent study which have shown that the patient has no history of OSC or no history of hypotension, there's a lower risk of bleeding. And the high risk of bleeding is associated with no staple-led reinforcement and low level of surgical expertise. So prevention depends on careful hemostasis. Please spend enough time on checking the staple and hemostasis. That's probably the most important step. It can be done quickly, but sometimes enough time should spend on the hemostasis. Adequate compression time for the stapler. Withdraw the bougie before you check for bleeding. Ask the anesthetist about the blood pressure. Blood pressure should be around 140 millimeter of mercury, or roughly more than 30% above the, the baseline to check for bleeders. And it has been shown to reduce the bleeding rate by 1/3. Again, staple and reinforcement has been clearly shown to reduce bleeding. However, it costs. It can be in the form of overswing or buttressing material like, peristraps or Singard. However, we have relied entirely on 200 millimeter clips. You can see in this photograph, there are roughly about 8 to 10 clips. So if you're patient and you sort of catch hold of the oozers, the bleeders, put 200 clips, this is probably the cheapest way to control bleeding. Again, I said, don't rely on the drains. They just sort of may lead in early detection, but doesn't prevent the complication. Food intolerance is rarely, talked about. It's a very important issue after sleeve gastrectomy, and these are the various causes. An unrepaired hiatus hernia leading to a migration of the fundus, stricture, twisted sleeve, and king. And these have been found to be the important causes of food intolerance following sleeve gastrectomy, which can occur early in the post-operative period or late, as in a twisted fundus or a late stricture. So what is the etiology? I think the most important thing is which happens is we get too close to the incisura, or we are very aggressive about overswing of staple line. Like in our initial experience, overswing, we had some patients who presented and were readmitted with severe nausea and vomiting. Staple line overswing creates asymmetry, induces ischemia, and can also cause leaks. So in our own experience, we have given up the overswing of staple line totally, completely. It doesn't help in leaks, and it really causes more problems than benefits. So how do you prevent a stricture? So place a bougie. So this is just a very small clip showing how we should be very careful about the first firing. Always place a bougie before the first firing. Sometimes the it doesn't go, doesn't enter, take your time, place the bougie. Placing the bougie. And even after you place the bougie, the tip of the stapler at the time of first fire should be away from the incisor at least 2.5 centimeters as shown in this video, because there is an angulation there from the vertical to the horizontal part of the stomach. So even if you have a bougie, this can result in kinking if you are too close to the bougie. As I already said, avoid overzealous oversing of the staple line, or avoid any overswing at all as we practice. We don't practice any overswing. So once you do this, you see there is enough, width of the sleeve at the incisora, and you're not really too close to this thing. So what are the symptoms of when we say food intolerance? It can be in the form of recurrent vomiting, dysphagia, rapid weight loss, weakness or vernix encephalopathy, and one of the author described a common symptoms as BAF symptoms like bloating, abdominal pain, regurgitation, and food intolerance. And how do you evaluate these symptoms? Now, don't psychological issues. I've seen some of the patients being referred to a psychiatrist for these symptoms because they think everything is normal. We have done a good sleep. Take a good dietary history. Some leads to these sort of symptoms. However, we must investigate any sort of serious symptoms. Endoscopy is the first investigation, but maybe normally in the presence of twist or king, because the expert endoscopist can negotiate this twist or king. I would always recommend the surgeon to be endoscopy is done, or if you can do your own endoscopy, that would be wonderful. Barium studies are probably the investigation of choice, or you can do a CT scan with 3D reconstruction, or one may sometimes require diagnostic laparoscopy where external adhesions can lead to a kink or a twist of sleeve. And we have seen in 1 or 2 cases this has happened. Treatment is resuscitation. I won't go into details of that, but definitive management is eating behavior modification, endoscopic dilatation of any stricture, repair of any hiatus hernia, and surgery. If you're repairing hiatus hernia, maybe a good idea to convert to RYGB or do a stricturoplasty depending on the findings of the case. Reflux is a real controversial issue, but it's becoming important. One of the long-term complications of sleeve is reflux, and some of the recent papers have mentioned a very high incidence of Barrett's. But our own data on more than 80 endoscopies, I think it's touching 100 now, has shown only one case with the in a biopsy-proven Barrett's esophagus out of these, and more than roughly 90 endoscopies. So in our own experience, Barrett's is not an important issue. All the reflux is. And our philosophy is to be very aggressive about the hiatus hernia repair at the time of sleep. We roughly repair hiatus hernia in 1 in 4 cases. And I can show videos where hiatus hernia is so subtle. And if you dissect, you find a large defect. And you see hiatus hernia here, fundus is migrating up. There's a volume reflux on the, there's a twisting of the sleeve with reflux. So all these issues can occur if you do not pay attention to the technique. Again, most of the GERD do not require surgical treatment. Please remember that. It's 80 to 90% of these patients can be treated with just dietary modification, asking the patient to eat slowly, mindfully, give a trial of prokinetic agents and PPIs. And surgery is required in only limited cases. And so look at what are the indications of conversion. Severe symptoms or objective scoring systems are available, especially nocturnal reflux. In our own experience, patients who have nocturnal reflux, when they lie down, they have a food coming to their mouth, causing chronic cough and all that. Erosive esophagitis, LACD, volume reflux, as you can see on the picture on the right, and pH studies. All these things can indicate a conversion. And I'll just show you a small video where to how we do it. And today again we had a revision case where none of the investigations suggested a hiatus, but on proper dissection we found fundus going up. Patient had weight regain, and we did convert it to an MGB. Again, in this case, this patient was reflux. As you can appreciate, there's a large hiatus. We're dissecting the sleeve away from the left crust, large right crust. Meticulous dissection showing with fine scissors and harmonic. You can dissect the hiatus, convert to a bypass in the standard way. We use the omega loop technique. Take 70 centimeters from DJ junction. Use a blue cartridge in a revision case. Do a 3 centimeter anastomosis and close the enterotomy in a single layer using 20 PDS. And subsequently, we detach the BP limb, then do a Genostomy at about 130 centimeter from elementary lip from the GJ. Again, using white cartridge here because this is virgin area, and close the common enterotomy with 20 PDS. Following that, we close the mesenteric defects, and then we repair. We just had to repair it without the bougie, and the bougie is required for the leak test. So we, after we've done this, we so this is a high test repair. So just 2 or 3 sutures with endostitch or 10 proline is enough, and we ensure an adequate length of esophagus and appreciate of 3 centimeters to drain and come out. So this is required in certain limited cases. Again, most of the GR patients can be managed conservatively. Okay, I'll just go to the next slide. So how do you minimize the reflux? You must pay attention to the sleeve morphology. Avoid too narrow a sleeve. 38 to 40 French bougies or 32 to 34 French. As I said, pay close attention to filing the first stapler. Avoid any twists in the sleeve. Repair the hiatus hernias, which are clinically. And so just to conclude my talk, never, ignore patient's condition. Patient doesn't look good. It may be like confusion, patient not looking very awake, hypoxia, tachypnea, or all can be due to a leak. The symptoms of leak can present subtly and yet be rapidly fatal because this obese patient can have a very fast inflammatory response. So very close observation and decision making is required irrespective of the time of the day. If you do imaging, read films together with the radiologist. Our protocol is immediately consult the consultant radiologist and discuss the films with them. Again, explore a relapse as soon as possible or drain the collection as soon as possible. And do not let anyone in the team suggest, more imaging, more, you're waiting for the next day and saying, patient looks all right. The best diagnostic test is re-laparoscopy. Don't forget that. If you ever put imaging, the imaging is and the clinical findings are not matching, go in for a re-laparoscopy. You will never regret. Don't over-rely on imaging, especially if negative. Again, do not let the sun set on obstruction applies here as well. And you should do a prompt re-laparoscopy without regard to any convenience, schedule, or sleep time. Denial is dangerous and delay lethal. So if you want to prevent it, minimize the complications, always tell the patient what the complications can be. Counsel the patient that if they have fever, give them their phone numbers, whom to contact. If they have persistent vomiting, severe pain, so they should know when to call the surgeon on how to reach their surgical team. I hope I finished in time, roughly about 22 minutes. And this, I invite you to this course, basically for postgraduates in various medical colleges and various other centers, which is a 1.5-day course on basics of bariatric surgery. I know Sarfaraj is doing an advanced course in bariatric surgery in Kolkata, but this is a basic course in bariatric surgery. We are looking at roughly about 50 participants, and we are planning to give them complimentary accommodation as well in Delhi. And it will be a nice course which will show all the 3 basic procedures, discuss each procedures, the history, the technique, the complications, and the counseling, the dietary part. So it will be a nice, basic course. Roughly, whoever is interested, please, contact me or email at our forms website. Thank you so much. I'm open to questions now.
That was a wonderful talk, Dr. Sandeep, as usual. I think you covered the complete aspects of the prevention to management of sleep complications. And to start off with, I think you have a large experience in bariatric surgery and sleep gastrectomy for the last decade or so. Because the sleep complications continue to be there, including leak, which is probably the most dreaded complication. So what has been your learning curve in the way you have done your sleep gastrectomy since you started until now? And what would be your advice to the young surgeons who are starting up with sleep gastrectomy?
That's an extremely good question, I think. And if you look at some of the, all of us know that the sleep over the last 1 decade. When we started and now where we are, there are a lot of things which we have changed. And one thing which I have learned from my learning curve is don't be too aggressive about the tightness of sleep. It doesn't give you more weight loss. It only gives you complications. That is point number 1. Don't take sleeve as a simple operation. Today, when we had a sleep at about 3:30, I thought I'll finish it within 1 hour. Believe me, it was really one of the toughest sleeps I did today. The whole funda was stuck posterior. Don't take sleep as a simple procedure. It has its own nuances. Each fire planet, where to put it, equal retraction on both anterior and posterior surfaces. Be very meticulous about the hemostasis. And what has changed in our practice is not to be aggressive at the upper part of the sleeve. Don't dissect the angle of fat at angle is too aggressively, unless it's too large. Probably that is one thing I think I have changed, which has probably led to, luckily last two to 3 years we didn't have a leak. And one thing I can think of is do not dissect the fat at the angle of his too much, because that leads to hematoma. Besides other things, all other points I've talked about. I think these are my learning lessons, which I think I've learned. Of course, there are a lot of things. I think the hiatus and repair, which I mentioned in the presentation. We were not aggressive about it earlier. But now, if you dissect it nicely, you see it's fairly, even an awkward looking hiatus, once you dissect it, is fairly large. And it just takes another 10 minutes regularly. Don't ignore the hiatus. It's going to lead to reflux later on. And then everybody blames that sleep for reflux. So repair the hiatuses, learn how to repair it along with sleep gastrectomy. That'll be my answer.
Oh, great points and great learning for the youngsters, Sandeep. Now, I think going on to leak as such, let us say, for example, a surgeon who's in his early curve of his career has done a sleep gastrectomy. He notices leak on the 4th or the 5th day post-sleep gastrectomy. But let's say, for example, he hasn't managed a sleep leak earlier. So what should he do? So should he do something on his own along with the medical gastro that he's working with? Or should he intervene? Or should he refer to another surgical center? Or should he seek help? What will be your advice be?
Yeah, again, a great question. So if you look at our own experience, most of the leaks are small, because if we haven't created a blunder, misfired a stapler totally, most of the leaks are small. They present usually, as I said, 4th to 5th day. They lead to a localized collections, and patients are usually hemodynamic stable unless you have delayed the diagnosis or not drained the sepsis. So first thing first, drain the sepsis right away. There's no time left. If you diagnose sleep at 10 o'clock, drain it within the next few hours, either by re-laparoscopy. But if you have a good interventional radiologist, we have drained our collection even at night, because at AIIMS we have a very good department of radiology. But if you don't have it, go drain it at night. Don't wait till morning. Point number one. So there you don't need to refer any patient, please. If you're a bariatric surgeon, you're supposed to have good laparoscopic skills, you can drain it. Point number one. Don't, if you are not sure about feeding Genostomy, how to do it, it's easily said, so do a feeding Genostomy. It's not an easy procedure laparoscopically in obese patients. So if you can't do it, don't do it. You can always put a feeding tube later on. If you can do it, nice. But if you can't do it properly, don't, try to do it. So, and start antibiotics promptly. So if it is a controlled leak, you can get away in the initial period. And then you can talk to other colleagues, depending on, and if you have the expertise of the gastroenterologist, get it stented. We are not a great believer in stenting, but yes, stents have come up. Better stents are available. Patients ask for it because they will ask the other surgeons across the city. Once the leak is happened, believe me, it's a very difficult situation for the surgeon. Be honest with the patient. That's the best thing. So there's a leak. It happened. We have already told you pre-operatively. I already told you it takes 4 to 6 weeks for heal. So if you have counseled the patient well, no need to panic. You've not committed a crime or something. There's a leak. Manage it well. Talk to the patient morning, evening. See the patient. Communication. Patient will realize himself or herself that you're committed to their recovery. So I think a referral can come later on. If there's you have to manage it initially. This is my take on it.
Okay. So at what point in a sleep leak management would you consider that the endoscopic therapies are not working well, that would want to intervene with the surgical approach?
Yeah. So as I said, if you look at the approach, it can be conservative approach without stent or with stents, and most of them have a certain success rate. They don't have a 100% success rate. But let's say about 75 to 90% in the best of the hands. So remaining 10 to 15, 20% would require some sort of surgery. It may include a total gastrectomy or a conversion to bypass if it's not very high. So I think those are left to the trained surgeons or very experienced surgeons. So I would, If you are, not, very experienced, refer then case. That's the time for referral, because these are extremely complex cases. We had last leak, we took the help of GI surgeons because it was really complex. Almost 3 months later, patient presented again with a re-leak, small leak, but went into sepsis, controlled, and we had to do a laparotomy. Believe me, it's a very difficult situation. Don't do it yourself. Take the help of a senior GI surgeon or a senior surgeon or a colleague. I think that's the time for referral, because then you need a surgical management, the endoscopy management.
Great thoughts, Dr. Sandeep, and great learnings. Does any of the other moderators have any questions for Dr. Sandeep?
Can I ask one question, Praveen?
Sir, please, sir, go ahead.
Sandeep, excellent presentation.
Thank you.
One question regarding that revision thing with hiatus hernia. Should hiatus hernia or hiatal defect should always be repaired bypass, or you can repair while you are making gastric pouch?
Sorry, I missed the voice became up.
Okay, so I'll repeat So when there is a hiatus hernia with weight regain after sleeve, should hiatus hernia be repaired only after doing gastric bypass, or you can repair earlier also? You can repair while you are doing the gastric pouch and then go for the jejunal thing.
So as I said, we repair the hiatus hernia without a bougie, and normally we require the bougie for the leak test. That's the only point. So if you can do it after GJ itself, once you remove the bougie. So we have developed a stepwise approach. Like today's revision again. First, dissect the sleeve right till the hiatus, identify the left crust, look whether the fundus is going up, which is almost always there. Believe me, some fundus is always going up in weight regain cases. Get it down, get a good length of esophagus, convert to MGB or RYGB depending on what is the primary indication. If it is reflux, it's RYGB. If it's weight gain, it's MGB. Do all the steps of the bypass, repair the hiatus, and that's our approach. That's just because we don't want the bougie. Yeah.
Thank you.
Any questions from any of the moderators? If not, I think that was a great session. I think that was a great start for IAGES Prime Time. I'm sure all of you who watched this would have definitely enjoyed the presentation and the discussion. Thank you, Dr. Sandeep Agarwal, once again for that wonderful presentation. Over to Dr. Kanagvel for the rest of the session.
Thank you all the faculty. Thanks.
Thank you, Dr. Praveen. It's been a pleasure to be moderated by a eminent bariatric surgeon and being spoken by an eminent bariatric surgeon on this important area of sleep gastric. Now we move on to the next important issue. Now we have none other than a surgeon who has done 7,000 plus bariatric operations over the last 20 years. The director of the Bariatric in Ahmedabad and also operating from Rajkot. He is one of the very few surgeon of excellence certified by the American Society of Metabolic and Bariatric Surgery. And he takes special interest in training youngsters into the field of bariatric operation. And I'm sure with 7,000 surgeries plus to his credit, we are going to have a very dynamic moderation. I'm sure you're also having to listen to his experience during moderation. Can I have Dr. Sanjay Patolia, sir, to moderate this session?
Thank you, Dr. Kanagvel, for kind introduction. I must congratulate, first of all, the IAGES team for starting this IAGES Prime Time. I am very much sure that this team under leadership of Professor Sunil Popat will do well in scientific activity. Today we are going to, I'm going to moderate a session on complications Roux-en-Y gastric bypass. It is to be presented by respected Dr. Kula sir. Dr. Kula sir doesn't need any much introduction because he is a well-known bariatric surgeon. He is with respected Dr. Chobe sir working in the team. And as far as I know, the team is very much comfortable with performing Roux-en-Y gastric bypass, if not wrong, exclusively from beginning. So Dr. Kula can give better idea about complication of Roux-en-Y gastric bypass, having wide experience of treating patients with Roux-en-Y gastric bypass. We know Roux-en-Y gastric bypass is considered to be gold standard procedure in bariatric procedure. So everyone must understand complications of Roux-en-Y gastric bypass as well. So I must welcome Dr. Rajesh Kula sir to present his views and ideas on complications of Roux-en-Y gastric bypass. Please, sir, over to you.
Thank you, Dr. Sanjay Patolia. And I must thank the President, Professor Sunil Popat, Convener, Dr. Kanagwel, as well as the Secretary IAGES, Ishwamurthy.
Thank you.
It's been a wonderful, initiative by IAGES, which has become very popular and has been spreading the knowledge in different fields of endoscopic laparoscopic surgery. And I congratulate the leadership of IAGES for taking up this initiative. And I thank Sunil, I thank Kanagwel for inviting me for this session on complication of RYG. I'll share my screen. I bring greetings from the Max Institute of Laparoscopic, Endoscopic and Bariatric Surgery, Max Healthcare, New Delhi. Complications cannot be entirely eliminated, but early recognition and intervention can greatly improve the outcomes. That is one of the most important things every surgeon should understand. If a surgeon says that he has never done any complication, either he has not done enough surgery or he is lying. Because complication can happen even in the best of the hands. So it is very important to recognize the complication early to improve the outcomes. It is more apt in bariatric surgery because bariatric surgery is technically much more complex. Because these patients are complex patients. They may not have any comorbidity like diabetes, hypertension, but just their excess weight makes them a complex patient itself. Along with that, they are more prone to have comorbidities also, like diabetes, hypertension, sleep apnea. So all these conditions also make them more prone for developing complications. Now, after RYGB, the complications can be early or late, and any complication in these patients, they are challenging. The main reason for that is because there is no normal physiological response to the intra-abdominal sepsis. The intra-abdominal fat as well as the subcutaneous fat being so much, it becomes very difficult to do a proper physical examination to really find out the catastrophe which has happened in abdomen. These patients are difficult to undergo imaging studies, and because the patient's weight may be so much that your CT scan machine may not be able to handle that patient. All these things, they lead to delay in diagnosis and management. And the most important thing in a bariatric patient is the early diagnosis and early management. So what is necessary for this is to minimize the morbidity, we need a vigilant team. Bariatric surgery is a teamwork of anesthetist, surgeon, the intensivist, the physiotherapist, nutritionist. Now, this team has to be very vigilant, and when you see a patient, if you don't find anything happening in a normal way, you should be suspicious. So high index of suspicious is very important. And the most important is to have a low threshold for re-exploration. Believe me, Even a negative re-exploration on high suspicion will not cause any increased morbidity to the patient. But if there is a problem, early exploration will always be rewarded. Now, the early post-operative phase, the different complications which can occur, as very aptly told by Dr. Sandeep also after leak, after sleeve surgery, after Roux-en-Y gastric bypass also, you can have leak. The incidence ranges between 0.09 to 8.36. There could be a bleeding, hemorrhage, which ranges from 0.1 to 4. There could be bowel obstruction, or there could be a pulmonary embolism, which can happen after any bariatric surgery. Now, if you see these patients on the first post-op day, when you go for the round, you usually find that patient has minimal pain. There would be a serous fluid in the drain discharge if you have put in a drain. If there's no drain, it doesn't matter. The urine output is adequate. There is no tachycardia. There is no tachypnea. The BP is stable. Normally, when we go in the morning round, the patient is sitting up, reading the newspaper or talking to their relatives or taking a walk in the corridor in our recovery room. So these are the patients who are doing well and everything is going fine. But if there are different patients who is, when you go for the round, you see that there is tachycardia. The pulse may be more than 100 or 110. Now remember, the tachycardia for a person whose basal pulse was 60 during surgery, even 80 or 90 would be tachycardia. And if the basal pulse was 100 during surgery, even 110 would be a normal pulse for that. So you have to take tachycardia with the basal pulse rate which the patient had during surgery. Tachypnea and respiratory symptom. Patient is, you can see patient using the accessory muscle to breathe. May or may not complain of abdominal pain. Fever may or may not be there, but the most important is the anxious look on the patient. Patient is not looking happy. You know, you ask him, he says, I'm not really feeling too good. I have this problem, I have that problem. You know? So this should raise the the suspicion should be there in the mind of the surgeon. Unexplained tachycardia. And normally we send the counts and the hemoglobin early in the morning at 6 o'clock. And slight rise in the leukocyte count is normal, but a significant rise in leukocytes. Dehydration, the tongue is dry, patient is tachypneic, and the urine output is low. If you find these features, this warrants something to be done. In these patients, if these are the symptoms on day one, I think the best thing would be to do a re-laparoscopy in these patients, because if re-laparoscopy is done within 24 hours, the patient recovers as a normal post-operative patient. Yes, there is a role of doing a CT scan or doing a dye study, but doing that, you will waste 8 to 10 hours in getting those investigations done. Because as I said, it is not very easy to get the imaging done in these patients. So re-laparoscopy is very, very important. And during re-laparoscopy, you identify the leak. And as you have gone early, usually it is possible to suture, do a thorough lavage and put drains if you have not put before. If you have put one, put another one. And after bypass, the best thing is that you have the remnant stomach in which you can do a feeding gastrostomy, which is not a very difficult procedure as compared to a feeding genostomy. This helps in initial decompression of the remnant stomach, and maybe after 48 hours, you can start feeding through this gastrostomy to maintain the nutrition of the patient. This is the patient which we had to go in on the day one. And this is the finding. You can see the striking feature is that in this you don't find any bile as compared to the other leaks. There is no bile in the gastrojejunal leak. You see the clear fluid, and that's the gastrojejunostomy, and that's the perforation. You can see. You will see a spurt of fluid coming out of it. So it's a early perforation. You can see the suture. That's the staple line. It is at the junction of gastrojejunal anastomosis. The tissues are not that bad. They are holding the sutures. So with the 20 Vicryl or and once you have closed the perforation, it is not very difficult to do a gastrostomy. The remnant stomach is just lying by the side. Take a purse string suture, put in a Foley's catheter. And that's what needs to be done. And patient usually recovers without any event. Another leak can occur from is the jejunostomy. Although leak from jejunostomy is very, very rare. This is the only one leak we have had till now in last 20 years from the jejunostomy. And the reason is always iatrogenic, I would say. In jejunostomy leak, you will see bile, because jejunostomy, you have the alimentary limb and you have the biliopancreatic limb, so the bile will always be there. So if you see bile there, you know that the leak is not in the gastrojejunal anastomosis, but near the jejunum. So you have to see, and you see this is also done on day 1. That is why there is not much of edema in the bowel. You see the perforation on the posterior wall of the jejunum, and usually this perforation occurs if you are not very careful when you are doing and making the enterotomy in the jejunum, or if you are too enthusiastic in attaining hemostasis at the suture line. And the important thing is going early, you are able to close the perforation properly. And in this patient, this was what was necessary. Proper suction of the pus as well as putting in drains in the upper abdomen as well as in the this usually takes care of the leak and patient normally recovers. Now, the leak can also occur in the later phase, which is delayed leak, which usually occurs from 5 to 7 days after surgery. Usually by this time, the patient is back home and the presentation is pain, fever, and left hypochondrial pain. And on investigation, you have leukocytosis. And in this, you must do a CT scan, and which shows a left hypochondrial action. The management would be, depending upon the size of the collection, you can do a CT-guided drainage, or you can do a relaparoscopic drain and just do a feeding gastrostomy. At this stage, it is impossible to put sutures at the perforation site. And usually these patients with good feeding and good nutrition, they usually heals in 2 to 3 weeks, because as compared to the sleeve leak, Roux-en-Y bypass is a low pressure system. There is no high pressure in the pouch, so the perforation usually heals quickly. Second important complication is hemorrhage. Hemorrhage can occur intraluminal or it can be intra-abdominal. Now, the diagnosis is very important and it depends on the presentation, how the bleeding presents. It can present as hematemesis, then the bleeding is either from the GJ anastomosis or sometimes even gastric pouch bleeding, if it is significant, it can come in the alimentary limb and present as hematemesis. Patient may have melena. If melena is there, then the bleeding can occur from GJ, it can occur from pouch, it can occur from remnant, or it can occur from Genostomy. If there is bright red color per rectum, then it has to be a massive jejunal bleeding. And if you have blood in the drain, then it is intra-abdominal hemorrhage. Now, the treatment depends on the severity of hemorrhage. Usually it's a low volume and frequency, and if the drop in hemoglobin is less than 2 grams and the patient is hemodynamically stable, the management will only be that stop low molecular weight heparin and transfuse blood if hemoglobin is less than 8. You may have to transfuse 1, 2, or 3 units of blood. Most important thing is the hemodynamically stable patient. If the bleeding or hematemesis is more repeated episodes and large volume, whether it is hematemesis or melena, and patient shows signs of hypotension and the fall in hemoglobin is more than 2 grams, this warrants management. If it's hematemesis, then upper GI endoscopy and control of bleeding. And if it is melena, then re-laparoscopy and oversewing of all potential sites and all suture lines have to be done. The point to remember is that if you are doing upper GI endoscopy, then after that a contrast study is a must to rule out any perforation which can occur if endoscopy is done in an early phase. Extraluminal bleeding depends if the hemodynamically patient how is behaving. If the patient is stable, you continue conservative treatment. If the patient is not stable, you must re-laparoscope. And this is a patient we had to re-laparoscope, and the site of bleeding was from the remnant. This had formed a pseudoaneurysm, underrun the bleeder, and this is a flow seal which you can put on all the suture line to make sure, because many times when you do laparoscopy in these patients, the bleeding has already stopped. So you must make sure that there is no further bleeding from the suture line. Another important early complication is bowel obstruction, which can happen in the hernia if the patient has. Many of these patients have a small umbilical hernia which is not visible clinically, or they can develop hernia of the bowel at the port site, or there could be some anastomotic narrowing leading to bowel obstruction. Now, it is important to close the umbilical hernia if you have one, even if it was not present clinically, because once you divide the omentum in the 2/3, 1/3 region for the bypass, for the alimentary limb to go up, the bowel is exposed to the anterior abdominal wall. Omentum is not there in between. So the bowel has a tendency to herniate in the small umbilical hernia. So it must be suture closed. We do not advocate putting in the mesh, but we always advocate the umbilical hernia should be closed, and all 10 millimeter ports and above should be suture closed. Pulmonary embolism is also an early complication. The incidence is 0.8%, ranging from 0.04 to 2.24, and this is one of the leading cause of mortality after bariatric surgery. Fortunately, this is not very common, but it does happen occasionally, very rarely. The symptoms are usually tachycardia, tachypnea, hypotension, and hypoxemia. The investigations are ventilation perfusion scan, CT pulmonary angiography, and echo to diagnose this condition. And the treatment is basically anticoagulation in the form of heparin and ventilator support. But mortality and morbidity is very high in these patients, and prevention is the main key in these cases. And DVT prophylaxis is of utmost importance in bariatric patients. Early ambulation, lower extremity compression, which is used during surgery also, and pharmacotherapy in the form of low molecular weight heparin. All these three things are must in every bariatric patient to prevent complications of pulmonary embolism. So summarizing, the post-operative complications are the major cause of morbidity and mortality. Fortunately, these complications are much less and within acceptable limits. Limited diagnostic modalities are available in these patients. So a very high degree of suspicion by alert team is the key factor. And early detection and immediate intervention minimizes the mortality and morbidity in these patients. And I end my presentation by saying that the aim of science is not to attain infinite wisdom, but to eliminate the potential of infinite errors. Thank you very much.
Thank you very much for enlightening with your talk in regards of complications of Roux-en-Y gastric bypass. You have, sir, very well explained about management of leak in case of Roux-en-Y gastric bypass, specifically from pouch jejunal anastomosis leak as well as jejunal anastomosis leak. So what you have shown is re-laparoscopy is helping in managing leaks after Roux-en-Y gastric bypass. Sir, we would like to know whether endoscopic stenting in case of leak from pouch jejunal anastomosis from either from vertical staple line or from anastomotic staple line would be helpful, or when you consider for, is there any chance to consider for endoscopic stenting?
You see, endoscopic stenting is good for sleeve leaks because you want to convert high pressure system to a low pressure system. Now, Roux-en-Y gastric bypass, it's a low pressure system and it's a small pouch. And stents, I don't think have much role to play in case of GJ leaks after a Roux-en-Y gastric bypass. I think the important thing to understand is that, if you diagnose it early, the early closure of the perforation gives you the best results. If you put in a stent, the stent migration is very high in these patients. So I don't think there is much role of stent after a GJ leak in bypass.
Recently, I was discussing with our endoscopic colleagues, and he was suggesting about anti-migratory beta stent, which he was very much hopeful about it, and he was suggesting and trying to endoscopic stent in case of leak where patient is vitally stable. So that is, I think, opening up a new era for managing gastric leak after Roux-en-Y gastric bypass. And you have beautifully shown about managing jejunal anastomotic leak. Sir, any advice to prevent jejunal leak specifically for the beginners? Because you told that it is mainly iatrogenic leak when it comes to jejunal leak in Roux-en-Y gastric bypass.
Yeah, you see, the most important, if you people who are doing bypass, you have to do enterotomy in 2 limbs of jejunum to pass your stapler. Now, enterotomy is done either using cautery or using the ultracision. Now, if you are using cautery, if you're not careful, sometimes your activated hook can touch the posterior wall without your knowledge. And that can, cause later on leak. So when you are doing enterotomy for making a jejunal anastomosis, it is very important for your assistant to hold the loop well, put the loop under traction so that it is, you only go puncture the interior wall of the jejunum on both the loops and then you enter. Second very important thing is once you have passed your stapler, both the limbs, you must lift up. Before you fire, you must lift up your stapler so that the posterior part of the posterior wall mucosa doesn't come into your stapler. You see, it is not easy to put your scope inside the anastomosis to look at the inner anastomotic line. You see only the outer anastomotic line. So what the stapler has done inside, you have to be careful. So always lift up your stapler before you fire, and make sure that your two limbs of the staple are anvil and the staple are freely moving in the jejunal loops before you fire. This is very important to prevent any injury, iatrogenic injury in the jejunal, because otherwise there is no reason for jejunal anastomosis to leak. And what you saw in the video, that was not from the anastomotic line, it was a little away from the staple line. So, and this is the only one which we had.
Yeah,
it's a very rare operation. Yeah.
And sometimes in case of struggle, we may injure the intestinal wall with the tip of stapler. And that's also important factor which we need to take care about.
Yeah, absolutely.
Sir, regarding intestinal obstruction, internal hernia is very important factor which we should never forget. So we would like to have some advice or some tips, or what is your practice to prevent internal hernia, that I think every beginner or every junior surgeon who wants to start bariatric program, they must understand, and they should not neglect it.
Yeah, you see, I didn't discuss internal hernia because that complication usually occurs little late. Once the patient has lost some weight, then the internal hernia, there is more tendency for internal hernia to develop. Normally, what we have seen internal hernia occurring after 3 to 6 months, earliest after 3 to 6 months of Roux-en-Y gastric bypass. It is 100% importance that both the jejunal as well as the Peterson defects should be closed. Why I'm saying so is because when we started our bariatric program, there were reports, whether you close or you don't close, the incidence of hernia is same. So we were not closing. Okay, so after 4 years of doing number of bariatric patients, we started getting our share of internal hernia. So we started getting internal hernia from the jejunal defect. We got 4 or 5 of them in a row. Then we thought, no, we must close the jejunal defect. Peterson doesn't occur. So we started closing jejunal defect. After 2-3 years of that, we started getting Peterson hernia, internal hernias. So we have experienced from our own personal learning, we have learned that both the defects should be closed. That is the only safeguard to reduce. And we have even published a paper in obesity surgery, our experience, that closure of both the defects definitely reduces the incidence of internal hernia. Because we have seen internal hernias and we have had all, share early presentation, late presentation. 2 cases we had to do massive gut resection to save the patient. But most of the cases we could reduce the hernia in time and salvage the patients. But the internal hernia, you must close both the defects. Very, very important.
True, sir. So majority of surgeons who are now strongly believing to close both the defects, they have the same experience which you have mentioned. So that's very important to understand the closure of both the defects.
Yeah.
Sir, gastric bypass is very well established for the weight maintenance effect as compared to other procedure, I mean the restrictive procedure. So do you think banded procedure can give better results in terms of weight maintenance as compared to non-banded bypass?
Yes, that is a very important question. I have my reservation about the band. We started our bariatric program with the gastric band, you know that. And a time came when we had to remove all those gastric bands. The banded band placed over the pouch in RYGB is a very loose, band, which does not even encircle. There is always a gap between the pouch. Now, I'm not able to understand that how this placed band, which is not causing any obstruction or any, pouch is not dilated as yet. but still banded bypass gives better results in first 6 months as compared to non-banded. I do not know how it happens. The day that band starts making its effect for not letting the pouch to dilate, it will cause erosion and will come inside the stomach. So there are enough reports of bands being eroded into the gastric pouch in which banded bypass has done. The weight regain after Roux-en-Y bypass has got multifaceted factors, which include from eating habits, the patient's habitat, the eating habits. The size of the pouch, I would say, is much more important. Size and the volume of the pouch is much more important as compared to placing a band around the pouch for maintenance of weight. That is my personal view. There may be different people. There are so many people who are in favor of even putting a band on the sleeve. I do not see the logic putting a band on the sleeve. But there are, you will find different people, different surgeons experimenting, and that is the only way to progress, I would say. If you don't do odd things, you will not come across with new things. But my personal feeling is that if foreign body placed around a narrow tube, once the tube starts dilating, that band will erode inside the stomach. The purpose of band will go. So that is why we have not started putting band. We have not put till now even a single band. We are doing standard Roux-en-Y gastric bypass, small pouch, 30 ml pouch, and we have good results. I'm quite happy with that.
True. Sir, last question I would like to ask about reversibility of the gastric bypass. Gastric bypass is reversible procedure.
Yes.
Sir, we would like to know about the indications where you selected your patient for complete reversal.
Yeah. 2 patients we reversed when patient came with internal hernia. We did a massive resection and reversed the bypass, and patient recovered well, did well. 1 patient we had to reverse because patient could not tolerate bypass. There was excessive weight loss and the patient could not manage with the bypass, and we had to reverse it. We have reversed only 3 patients till now of bypass, and that has been only the indications. So 2 were to save the life, because once you have done a massive resection, small bowel resection, there was only 2 meters of 1.5 meter of bowel left. So we did a gastrostomy, fire stapler gastrostomy pouch to the remnant stomach. And same thing was done in this last patient who had come down from 120 kg to 45 kg and could not maintain herself. So we reversed it. And she's doing well.
Okay. Thank you, sir, for your enlightening session on complications, and with answers to our questions. We got detailed information, and thank you so much, Dr. Agarwal, Dr. Sunil Popat, for the scientific program. Thank you very much.
Thank you very much. Yeah, thank you very much, Sunil. It was a wonderful session. Thank you, Sunil. Thank you, Agarwal. And thank you, everyone who is participating in this session for this wonderful program. Thank you.
Thank you, Dr. Kullar. Always your teaching is excellent, and we all enjoy it. Wonderful.
Thank you.
Thank you, Dr. Rajesh Kullar. It's been a lot of learning for us in such a short. Thank you, Dr. Sanjay. It's been a pleasure having you as a moderator for this program. Considering the time, I take your permission to move on to the next session. Now we have the pleasant honor of inviting the president of the OSSI, none other than Dr. Manish Ketan. And Manish Ketan himself, being a gold medalist
during his MS from the Gujarat University, and who has done 4,000 plus bariatric procedures to his credit. And more so, the No Obesity Center at the KD Hospital has also been pioneering in the follow-up of these patients, either done by that center or done by any other center, where the follow-up of bariatric surgery is a lifetime marriage with the patient and the bariatric team. The concept has been assimilated and created and has been successfully maintained by the KD Hospital team. Dr. Manish has been trained at the University of California and Professor Hinge, the most eminent bariatric surgeon of that particular time period. And he has borne the torch of learning from the California to the benefit of our country and the benefit of our fellowship students. The amount of students which he has been trained in the last 20 years has proven well the amount of strict training which has been imparted by Dr. Manish Kaitan. And during his tenure, OSSI also has seen greater heights. They've had their own journals started up, a lot of exciting academics happening on OSSI. And IAGES, our leadership, our president has been instrumental in bringing the fellow societies to our ambit so that the academic wins. May I have the honor of inviting Dr. Manish Kaitan to moderate this session. Over to you, sir.
Thank you, Dr. Gangavel, and thank you, Dr. Popat and IAGES for inviting me. So without wasting much time, I would like to introduce one of my very good friends and immediate past president of OSSI, who has been a pioneer in not only bariatric surgery, but robotic surgery. And being since in the capital of our country, a lot of people have attention, have learned from him. And those are the days when I started bariatric surgery. I see him talking about complications on band. So he's one of the senior fellows who has got quite good experience, and he is also the president of the Society of MGB, that is OAGB now, one anastomotic gastric bypass. So I invite Dr. Arun Prasad and FRCS to talk on complication of one anastomotic gastric bypass. So Arun, all to you, please.
Thank you, Manish, for those kind words, and nice to see you and nice to see everybody else. Congratulations to Sunil and the entire IAGES team for this wonderful Primetime series, which now has become quite a popular event, and we all look forward to it every fortnight. So I'll get on with my topic, which is on the complications of Gb Oagb. So I'll start with my screen share. So when we talk about Gb Oagb complications, we could divide these into intraoperative, early post-operative, delayed post-operative, and late complications. The intraoperative complications can start with bleeding in the lesser curve entry. So the first step which we do during MGB is entering the lesser curve, and while entering you can encounter some bleeding which can be annoying. Hence it's very important to patiently take this step, because once you've made this opening, after this the chances of bleeding reduces. Then at the same time, you can also cause an injury in the lesser curve while you are trying to make this window. So this first step can be of a problem, and one should not be in a hurry to start off. So be gentle, be patient. As soon as you have opened this window, the rest of the procedure becomes relatively easier. Then while making the pouch, you can have stapler failure. Next problematic area is towards the end of your pouch making, the sleeve which you are making, and that is when you are doing a retrofundal stapling. So you can get bleeding there. Now, many MGB surgeons would say that there is no point in dissecting out that area, and we keep firing our stapler till we reach the end. Even if you don't disconnect, it's not a problem. But I think here personally, I feel that going by the RYGB experience, one should bring the fundus down by opening up the area under the diaphragm, that peritoneum, because once you bring the fundus down, then this retrofundal dissection becomes easy, and the chances of your bleeding in that area near the spleen gets reduced. So bring the fundus down like you do in RYGB, make a window there and fire the stapler to reduce these chances. Twisted pouch is another problem. I think this has been dealt with nicely by previous speaker during the sleeve, and you need to avoid twisting of the pouch because a twisted pouch can give rise to a lot of post-operative symptoms. So when you are firing your stapler, make sure that your stapler is coming on the top, a little bit of anti-clockwise twist of your gun is what is required. So I'll take you through a few videos, interesting videos. Now this is an MGB which has been completed. We've just done a leak test, and what do we see here? That's methylene blue coming out of the efferent limb of the MGB. Now this has happened because the assistant who was holding on to this limb while we were doing the surgery has probably been over powerful and has made a hole there. So importance of doing a leak test here is not just the anastomosis, but it can help you identify other coincidental bowel injury that might have taken place during your surgery without your knowledge. So we've now sutured that hole, and we did another leak test, and this seemed fine, so there was no problem. Then this is another interesting case. This is a robotic MGB going on. The MGB pouch has been formed. The jejunum is being taken up, and we do a gastrojejunostomy. After doing the gastrojejunostomy, we start suturing and ask for the GCT to be passed. But the GCT is not going through the anastomosis, even though it was a 6 centimeter, 60 mm wide anastomosis. So what's wrong? And suddenly we find, what's this? So what has happened here? There is the anastomosis, but the GCT is on the left. So what happened is that once we made the pouch, this patient had a very floppy stomach and fundus up there, and the fundus flopped down. The omentum is hiding the actual pouch, and it's the fundus which is lying up. So what I did was I pulled that fundus down and did world's first fundojejunostomy. So now to correct it, we've done a excision of that, and a small Roux limb has been created. So this Roux limb is now being anastomosed, and what we are doing is some sort of a GCT is now passed nicely across this. The anastomosis is closed. The extra segment is excised. We do a jejunostomy to complete the Roux-en-Y. Another case here. Here what we see is after the leak test, we see this white spot. So how did this happen? This was probably the cause that when you make the enterotomy with the harmonic there, the tip has probably gone and touched the opposite side. And this could have led to a delayed perforation, ischemic perforation at a later date. So what next? As this has been identified, all we did was did a serosal to serosa suturing to bury that white spot. Early post-operative, we can have a gastrojejunostomy leak or we can have bleeding. Now, gastrojejunostomy leak in MGB causes biliary peritonitis. So this is something which goes in its favor or it goes against. That's something a matter of debate. But all I can say is that if there is a GJ leak, a biliary peritonitis, it's going to be picked up very fast because the patient is going to be in tremendous pain. So the diagnosis of this GJ leak is clinical, and whenever that happens, patient is in agony and pain, and you immediately know that this is perhaps a GJ leak because of the features of biliary peritonitis. I thank Dr. Sarfaraz Beg for allowing me to show this video. And here you can see an early diagnosis of biliary leak from the MGB anastomosis. So it was diagnosed early and hence they were able to suture nicely and the patient did well. Next, as we've got a long staple line as on the sleeve pouch, there is always a possibility of a staple line bleed. I thank Dr. Tantia for allowing me to share this video of his. And what you can see there is a bleeder there. So it's a wash extra suction cannula. The bleeder is identified. It's controlled with a combination of clips and overrunning of the staple line. Here is another case, leak as you can see. And after going in, we find that the anastomosis is fairly clear. There is no leakage from the gastrojejunal anastomosis. So that creates a confusion. So then we go up further, ask the anesthetist to pass the gastric calibration tube again and put in some methylene blue dye. And what you see here is a leakage from the sleeve pouch much above the area of our anastomosis. So it's not necessary that you will get leak from the anastomosis. You can also get leak from the sleeve pouch is the message from this particular video. So suture and lavage and drain. Talking about delayed post-operative complications, hypoglycemia, like any bypass, is a problem, and that is to be managed by patient education, modification of diet, giving small meals, giving certain supplements. Dumping also forms the same group, can give acarbose, and there are many methods of handling this problem. So hypoglycemia and dumping are inherent, and these are some symptoms which the patient can face. Diarrhea can happen mainly because of the malabsorption part. It will happen more if you have bypassed a longer segment. Then patient often complains of vague abdominal pains. So whenever a patient complains of vague abdominal pain, later, many months after the surgery, one should also consider a stomal ulcer. Because at times I have found that a patient with vague abdominal pain, weight regain, vomiting, sometimes excessive weight loss, and you do an endoscopy and you find a stomal ulcer. So vague abdominal pains should not be ignored. Further late complications, anemia is a very common complication because of problem with iron absorption. So is vitamin D and calcium deficiency. So anemia, vitamin D, these two have to be tackled, and one should assume that all our MGB patients are going to have problem of anemia and vitamin D, and they have to take this supplement lifelong or at least on a long-term basis. Some people get hyperproteinemia, especially ones where there is a combination of both malabsorption as well as low intake of protein, maybe because they are vegetarians, maybe because they don't like to eat much protein, combined with the malabsorption. So hypoproteinemia can be a feature. You can quickly diagnose these by, patients can complain of swelling of the feet. So edema of the feet can give rise to, alarm bells that could this be hypoproteinemia. Bile reflux is the other late complication. Bile reflux quite often happens because in MGB, the surgeon has not made the pouch long enough, because the pouch has to be fairly large. You should have close to 20 centimeters of the pouch so that your anastomosis, the gastrojejunostomy, is far away from the GE junction. However, in some patients, despite a long pouch, we could get bile reflux, and this has to be managed conservatively again by diet and giving certain medications. Excess weight loss can be a problem, and that may require giving patient higher calorie diet and even opting for reversal at times. And this can at times also be because the surgeon was over enthusiastic and has bypassed a very long segment. Weight regain is rare because MGB perhaps gives one of the best weight loss amongst all the procedures which we have spoken about. But we can get weight regain. There we have to do a dietary recall, try to find out what is the problem. Maybe, have a program of diet exercise to do something about it. Really, if after everything else, if the weight regain is a problem, one has to give up and say that, sorry, bariatric surgery has failed you. There's not much you can do. Inadequate weight loss has options. You can do a gastroplasty if you've got a wide sleeve. You can consider putting a band like Rajesh was just talking about earlier. So you can put a band on top of the MGB. You can also increase the limb length and increase the malabsorption. So these are the few things one can do about for an inadequate weight loss or a weight regain. How much success we will get is debatable, because a lot of these revision procedures sound very good on paper, but when you do it for a patient, they may not give you that much of a help. So dietary recall, nutritional deficiency, bypass length measurement, all these things are important when we are dealing with an inadequate weight loss or weight regain. When we talk about redo surgery, we could be doing redo surgery after an MGB because there is nutritional deficiency, or if there is severe GERD, dumping syndrome which is not being managed, marginal ulcers not healing, anastomotic stenosis. So these are the situations where one could consider doing a redo surgery in these MGB patients. So what are the redo surgeries? There are a few techniques. One is a Lonroth technique. I've drawn a diagram there. So on the left, if you see that MGB and the common channel and the BP limb, if you can see, that's the direction in which I've made it. So what can be done in this Lonroth technique is that you divide the BP limb and shift it further. So then that becomes the alimentary limb, the BP limb, and the common channel. So you convert this into an RYGB by the Lonroth technique. Rutledge has another technique of his in which he, instead of dividing the intestine there, he divides the GJ and divides the GJ and shifts it, and then it causes an alimentary limb and a common channel there. A third option is that you revise the entire procedure. which means you divide the GJ, you divide the anastomosis on both sides and create a proper RYGB. Lastly, sometimes we could be requiring reversal of MGB. So when we have to do a reversal of MGB, we just divide above the gastrojejunectomy. The gastrostomy is stapled and the jejunum staple flush to the GJ, and you can do a resection anastomosis of that area, which can be done lab, or as most of these patients have lost a lot of weight, if the surgeon is not confident, because this reversal procedure is going to be a very rare procedure any bariatric surgeon is going to be doing in his bariatric career. So you can also talk about doing this part open surgery rather than a lap surgery in case you are not experienced. So one of the points here regarding reversal. So to summarize, all surgeries are prone to complications. Awareness is the first step in management of any complication. Prevention, early action is very important. I would underline early action because complications are bound to happen with everybody who does surgeries. What is crucial is if you can diagnose early and take early action, you will be able to salvage the situation. So a wise surgeon learns from experience, and a wiser surgeon learns from others' experience. With those, I will come to the end of my talk, and thank you very much once more for inviting me to this prestigious IAGES Prime event.
Great talk, Dr. Arun. And I'll start from first thing. First, we are talking of GJ leaks. Suppose there is no problem with your anastomosis, there is no problem from the handling of the surgeon, and the GJ leak is disastrous in OAGB. So what extra steps to prevent GJ leak? There is no injury by your assistant, there is no injury, a thermal injury to your loop. And as you know, AGB leaks are, RYGB leaks are less common than MGB leaks. RYGB, GJ leaks are very, very less common. MGB leaks are still heard of. So what extra step would you advise to the young surgeons to prevent these GJ leaks? Except all those things which are mechanical, which can happen, I can understand.
Sure. So the extra steps which we can take in today's day and age is to also do an ICG dye test, which can tell you more about the vascularity of the area which you are anastomosing, both before and after the anastomosis. Because nowadays, most of the systems which we have the facility of ICG. ICG dye hardly costs 100 rupees. Even the current robotic surgery which we are doing, that also has an ICG monitor. The latest Olympus stores or Stryker equipment, they have ICG. So that is one area to consider, because vascularity is something which you may not be able to appreciate that well during your surgery. Mechanical factors, as you say, have already been ruled out. Then do your anastomosis slowly. I think I would stress on that. Do not be in a hurry. You don't have to race with yourself or with any other surgeon. Do the anastomosis slowly. And I have always been practicing a leak test at the end of my procedure. So I would always want to do a leak test.
Just a question, Dr. Arun. What is the importance of a hinge stitch at the end of the anastomosis between jejunum and gastrum? Because the end staplers are loose staplers. They are not as tight as the staplers which are starting. And the leak may happen from there because this anastomosis is under little tension more than RYGB. Is there an importance of a hinge stitch?
Yeah, see, what happens is normally you almost always put an end stitch, because when you are closing your hole of the gastroenterostomy which you have made, that stitch line carries on because you never stitch it right at the end. So you just have to take 2 or 3 extra bites and you will end up doing this stitch which you are going to hinge it up. And I think that's a good idea. Most of us do it inadvertently even without realizing we are doing it.
Yeah. So that's a great point. And second is bleeding. Now,
In fact, when we talk about, we talk about MGB/OAGB, but there are quite a lot of differences. That is something which can be discussed in a more focused bariatric meeting. And one of the things which the OAGB insists is that the anastomosis, the stomach and the jejunum, for about 2 centimeters above the anastomosis, they should be stitched further. The reason they give for that is to prevent reflux, but at the same time, as you are trying to say, it also helps by giving that kind of a hinge.
Sure. Arun, I think it is a very great point, because in my experience also, I would say that stitch is going to not put any stress on your steptor and holding the intestine, because the anastomosis is some stress. Second, we were talking about bleeding. So I heard Dr. Sandeep Agarwal and totally agree about it. In most of the bleedings, once you have completed your surgery and you know there is no bleeding, you come out. And if anything occurs, mostly you have to recognize it early and you have to manage it conservatively. So in MGB, why we have to intervene in a case of bleeding? Why can't we manage it conservatively?
No, I think the management of conservative versus intervention for the bleed post-op follows the same GI principles like any gastrointestinal surgery. There is nothing special about bariatric there. The only thing is that perhaps I feel that the decision to go in and suture has to be a little more early compared to regular patients, because we are dealing with patients who are morbidly obese, and a delay puts most of your patients on the ventilator for a day or two. Even if you just go in, suture, come out, everything is fine, still a redo surgery in a morbidly obese puts them on the ventilator for a day or two, and the longer you delay, the more the risks. So for that reason perhaps, but otherwise the principles have to be the same. Whether you manage by conservative or go in by the intervention, you need to see the drop in hemoglobin, the pulse, the BP, you do an endoscopy, you follow the same protocol as any GI surgery.
Definitely, I agree to it, and I also will like to add, because there are two staple lines here. In sleep, you have got only single staple line. There is a staple line towards the remnant, and there is a staple line towards the pouch. So the bleeding can be disastrous sometimes, and more fall in hemoglobin may be there. And you are very correct, in MGB, the bleeding has to be addressed more aggressively than any other surgery. And I totally agree to you, whatever you are saying. See, there is one complication I like to talk about. You have talked about biliary reflux, you have talked about how to manage it, you have talked about malnutrition, you have talked about how to manage it. Standardization of limb, I'm not going to talk about it because it is again a very debatable question, will be a lot. But what about obstruction? If there is an obstruction, two questions. One, there is an obstruction, there is remnant stomach dilatation. And what is your point once there is an obstruction? Because these obstructions are different from RYGB obstructions. Once there is an obstruction in the efferent limb, immediately there will be vomiting. But once there is an obstruction in efferent limb, if there is an obstruction, there is a vomiting. And once there is an obstruction in the efferent limb, there will be a stomach dilatation.
Yes.
And the blowout is going to be disastrous. So what is going to be your take on that? And second question I'll add, what is your take about Peterson's closure in one anastomosis gastric bypass? These are my last questions.
Right. No, that's a very good point you pointed out. In fact, I'm going to, after the end of this meeting, I'm going to modify my presentation and add a slide on that. The afferent limb obstruction, one has to be aware of. So awareness is most crucial, because only if you are aware of it, you will be able to diagnose it. And the diagnosis is generally made by a CT scan. So once you make a diagnosis, then once you suspect, you do a CT scan. Once you have diagnosed, then you will have to go inside and rectify that problem. So awareness, as I would underline, is the most important point here. The second point you mentioned was about Peterson defect. See, I have not been closing the Peterson defect, but we've heard one or two odd reports here and there about hernias from the Peterson defect. Now, exactly why that hernia happened, what was the situation in those rare cases, we don't know. So I think jury is still out. Currently, I'm not closing, and I've been doing this for quite some time now. Since 2011, I've been doing MGB. None of my patients have come back to me with that. And if in due course of time, guidelines change and it becomes mandatory, then it's not a problem, because to close the Peterson defect in MGB is much easier than closing the same in an RYGB.
Yes, my take would be for young surgeons, not an experienced surgeons like you, which may take time and our patients come from far away. So taking 2 minutes to close Peterson's is not going to do any harm rather than not closing it. And third thing is, in malnutrition, I forgot to ask you, in malnutrition, if you fail to recover the patient by your diet plan and nutrition plan, do you think doing a remnant gastrostomy and feeding from that can be a good option to help them to recover from that, or straightway you want to reverse the procedure?
See, I have done this reversal only once. And in fact, I think I remember having discussed that case with you. And I discussed that case with about 5 or 6 surgeons across, including Rutledge. And I got a 50-50 response. Half the people said, no, go in immediately and do a reversal, while other half said, do a gastrostomy. I, being little more conservative, I went for the feeding gastrostomy. So I put in the feeding gastrostomy, gave the patient some nutrition from there, and 6 weeks later, then I did the reversal and closed the gastrostomy after that. So I was quite happy with the results there. With experience of just one patient, I cannot say that I'm an expert, but I was happy with the results of a two-stage procedure of a gastrostomy, because I was a little scared to do the reversal in a hypoalbuminic patient who, if she leaked after that in that bad nutritional state, things would have become more disastrous and we would have had a problem there.
Yeah, great learning, Dr. Arun. I do agree totally for you in our YGB or VGB. If we do have a very bad patient with a very bad hypoproteinemia, first nourish them nicely and do a reversal. There is no harm in it. So this is not only my view, there are people published around it. So a very nice talk, and the forum is open for other moderators to ask any question from my side. The OAGB is so nice and so new and so controversial sometimes. There can be endless questions to it. But in the paucity of time, we will have another meeting for it to talk about it. Any moderators, if you want to ask questions.
Thanks Manish, and thanks Arun, wonderful presentation and excellent videos you showed. First in the world you showed that new kind of anastomosis, but it can definitely happen. I mean, people have reported various kinds of anastomotic failures. So wonderful. One question I just wanted to ask. We had earlier little discussion regarding sleeve. After sleeve, there is weight regain, and then there is a reflux problem. Patient coming to you, would you offer MGB or would you offer RYGB, or how would you proceed?
See, there is again no literature or consensus on this topic. And as a surgeon who does both RYGB and MGB, I personally would offer an RYGB in the people who have come with a reflux, and an MGB in patients who have come with weight regain, for the simple reason that anatomically, or at least theoretically, the RYGB will be giving a longer gap for the bile to reach the G junction. So the distance is much more. And the weight regain, I would offer an MGB because a restrictive procedure has already failed. So we should go for a strong malabsorptive procedure. Hence, in weight regain, I offer them MGB.
But after MGB, is there not a chance of bile reflux?
No. See, patients of bile reflux, I will tell them I will go for an RYGB. And patients with weight regain, I will go for an RY, for an MGB.
So if the patient is having hiatus hernia post-sleeve with weight regain, how to proceed?
Weight regain with hiatus hernia, I think I would prefer to do a Roux-en-Y bypass and also close the defect at the same time.
Thank you. Thank you. Nagwal?
Thank you, Dr. Arun and Dr. Manish. It's been a pleasure listening to you. And I think Arun Prasad sir was he shared all his own complications, and he took pains to collect all the other complications on this important procedure. Now, with the permission of the moderator and the faculty, we move on to the next session. Ladies and gentlemen, now I have the honor of inviting the most eminent women bariatric surgeon who has 2,500 bariatric procedures under her experience in the last 15, 16 years. And Madam Aparna has been from the Mahatma Gandhi Institute of Medical Sciences, Sevagram. And since then, he has spent time with Saifi Hospital and has been trained globally at various centers. She also has the coveted certification of the Surgeon of Excellence from the ASMBS. Later on, she is now into the leadership of the Obesity Center in Mumbai, where she is exclusively concentrating on bariatric surgery and little bit of foregut surgery and hernia surgery as well. Ladies and gentlemen, I also should share, she is a brilliant artist by herself, and she has, one should take time to visit her website, which displays the various artworks, and she helps a lot of underprivileged community, and she has been head of one important trust, which does a lot of good work for the welfare of the downtrodden. With that few words, may I have the honor of inviting Dr. Aparna Govil ma'am on behalf of the IAGES Primetime to moderate this session. Over to you, ma'am.
Thank you so much, Dr. Kanagwal, for this wonderful introduction. And at the outset, I would really like to thank IAGES and President Dr. Sandeep Popat, as well as Dr. Ishwar Murthy. And I think it's a very important session on complications because however good we may be and technically correct we may be, ultimately law of averages will catch up with each and every one of us. And finally, I think surgeons are the people with the least amount of ego. Having said that, I think it's a really positive move to include nutritional complications after bariatric surgery, because as surgeons, we only focus on surgical complications. But bariatrics, as we all know, is not just about surgery. It's about a lot of other things. And with that, I take the honor of introducing the very, very eminent and knowledgeable Dr. Sarfaraz Baig, who is the director of Digestive Surgery Clinic in Kolkata, India. He has also authored a book called Nutrition, Obesity and Bariatric Surgery. We've also had the pleasure of working together on another book, and we are both co-editors on that, and that is about the management of nutritional and metabolic complications of bariatric surgery. Of course, I think if we keep talking about him, we will not really have the session, we'll just keep talking about him. He is also a great poet, philosopher, singer, and the list just goes on. So I think with that, I would like to invite Dr. Baig for his very interesting lecture. Thank you.
Thank you, Aparna. Thank you, Dr. Kanagwal. Thank you, IAGES. Thank you, Dr. Sunil Popat. I think it's 10:30. Either we have finished dinner or we're going to have dinner. Don't want to be either ways obstructing any time schedule. So I'll go straight away to the talk that I have been given. Diagnosis and management of nutritional deficiencies after bariatric surgery. First of all, we are all bariatric surgeons. We know that we are either causing a reduction in the gastric volume, or we are simultaneously bypassing duodenum and proximal jejunum in the three most common bariatric procedures done across the world. Which means we need to know what is it that we bypass when we bypass the duodenum and the jejunum. Also, what happens if we cut the hydrochloric acid by gastric reduction. In a nutshell, this particular photograph or diagram gives an idea about what is happening. The body
wants to absorb all the important things in the proximal gut. Unfortunately, bariatric surgeons have to work on the proximal gut. And therefore, we tend to lose macronutrients and micronutrients. Amongst the macronutrients is the protein and essential fatty acids at times, which are lost because of malabsorption and differentials in pH and many things which contribute. And as far as micronutrients are concerned, the two most important metals, iron and calcium, which is absorbed in the duodenum by active transportation, that is being lost. And that is why we talk so much about anemia and bone health after bariatric surgery. At least this overview is important to understand what is going to come up next. So the reasons why this is happening is because there is low calorie intake after bariatric surgery, there's malabsorption, the duodenum, which is a very important source of absorption of vital micronutrients, are being bypassed, there is hypochlorhydria, and we also realize that there is food intolerance after bariatric surgery. All of this contribute to nutritional deficiencies. If I had to put it on one picture, what macronutrients are going to be affected most is the protein, because amino acids are absorbed in the jejunum. You may now start thinking that in a sleeve gastrectomy, the duodenum is not bypassed, jejunum is not bypassed. Therefore, it might sound that it is very innocuous and innocent. Actually, it is not. The reason being that with a sleeve gastrectomy, there is hypermotility in the duodenum, as seen and observed in the research, which reduces the contact time of the nutrients with the duodenum and the proximal jejunum, thus leading to a functional bypass. Therefore, these same things are happening both in sleeve and in bypass, or albeit I must say it's happening more in bypass. Amongst the micronutrients, the minerals like calcium and iron, as I mentioned, is going to get deficient. We have to be watchful on that. Zinc and copper being the other two. As far as the vitamins are concerned, fat-soluble vitamins are absorbed in the ileum. And since we work entirely on the foreguard, technically we should be thinking, well, it should not get malabsorbed. The A, D, E, and K. Actually, it's true. A, E, and K are rare deficiencies after bariatric surgery. But vitamin D, there is some deficiency. But again, after the surgery, one might see the vitamin D status improves because of less sequestration. But it is the water-soluble vitamins which are hit badly. B1, folate, B12, B6, B2, B3, all these are affected because they're all absorbed in the proximal jejunum. B12 is, however, absorbed in the ileum. Still, the problem why B12 gets malabsorbed is because the intrinsic factor produced in the antrum is cut down, and therefore that hampers the absorption, despite the fact that B12 is absorbed in the ileum. Therefore, if we were to understand the previous slide, it stands to reason that these bariatric patients are going to have iron deficiency anemia, also B12 and folic acid deficiency anemia, bone weaknesses because of calcium deficiency, protein energy malnutrition because the proteins are getting lost, especially if the bypass is more aggressive and radical. Hair loss, will come to telogen effluvium for some time in the subsequent slide, and neuropathy can happen at times because of B complex deficiency, and also there may be immunogenic reasons behind neuropathies. Let's just look at 4 or 5 case scenarios to understand how to diagnose and manage these. 38-year-old female had a Roux-en-Y gastric bypass, and at 1 year, she has exertional breathlessness. Well, when I climb stairs, I get breathless, doctor. Otherwise, I'm okay. Now, that should just make us suspect there could be anemia. And truly, the hemoglobin came as 8.9. At times, one may not find hemoglobin low, but rather you would find the iron is low or ferritin is low, and that will produce the same kind of symptoms. So we have to be aware of the fact that the hemoglobin may be normal. So what are the causes of iron deficiency anemia after bariatric surgery, which is the commonest problem, by the way, after bariatric surgery as far as nutrition is concerned? First thing is, make sure that the patient is not losing blood. Remember, 80% of bariatric patients are women in the reproductive age group. If they're having menorrhagia, that would be enough to cause iron deficiency anemia, and maybe we're not supplementing enough. Also, some of these patients do not tell us that they are having piles bleeding. That's also important to take. So while we rule out menorrhagia and piles, remember bariatric surgery itself can be ulcerogenic, like a gastric bypass could be ulcerogenic. And therefore, it's important to do endoscopy to rule out an ulcer bleed. What are the tests that we need to do in these patients? Well, because it's anemia, we do iron, ferritin, and TSAT, all three of them. Do not think that just doing a serum iron is enough. It's absolutely mandatory to do iron, ferritin, and TSAT together for meaningful interpretation. B12, folate, and albumin should also be measured to rule out anemia because of these deficiencies. These are the first line tests. But in our center, what we do is we always look at the peripheral blood smear. If we find it is microcytic, we think it must be an iron deficiency or a copper deficiency. Whereas if it is megaloblastic, it could be B12 and folate. And normocytic deficiency means there is a chronic inflammation going on. Most of these patients already have an ongoing chronic inflammation, and some of these will have a persistence of chronic inflammation. And some patients also have chronic liver disease, which is also a reason for chronic inflammation. So if we got a microcytic anemia in the peripheral smear, low iron, low ferritin, and normal B12 and folate, this is a classical iron deficiency anemia. But rarely would you find a picture like this in a bariatric patient. I'm not going to details, but I'll just say that nowadays it's important to remember that oral iron may not be tolerated by everyone. It may not be efficacious in everyone because of a phenomenon called chronic inflammation and hepcidin excess, which leads to suppression of iron incorporation for erythropoiesis. Therefore, intravenous iron is coming in a big way in bariatric armamentarium. And in fact, there is a tendency nowadays to talk about hepcidin levels as well to know, and the CRP levels to know if there's chronic inflammation, in which case oral iron may not be suitable. In these patients also, even if the B12 and folate is normal, we must add for adequate erythropoiesis. But what if all the tests come normal and the patient is still having a low hemoglobin? Then we do second line tests. That's copper, zinc, vitamin A and E. They can be responsible for anemia. Also, chronic diseases like cirrhosis and chronic kidney disease, not very uncommon with obese patients, may also be the reason. So that is one of the algorithms that we developed, but I think that's for another day. Refractory iron deficiency anemia, every time you find that there is, you give iron and the patient is not improving, think about chronic inflammation, think about hepcidin excess, think about giving intravenous iron. There is much more to come in this area, but I think that's beyond the ambit or scope of the topic of the talk today. Let's go to another case capsule. Another gastric bypass. On the 4th year, this patient has a low back pain, and she has stopped her supplements 2 years back. That's pretty common for a lot of patients who think that they are doing well. Why should they take an expensive supplement costing about 6,000 to 8,000 rupees a month? So she had a low back pain, radiation to the legs, and she was not responding to analgesics. So fortunately, she came to us and we could say, why don't you do something about it? Do an MRI or an X-ray. She said, why? We said, just do it. It's important. So think about osteopenia, fractures, disc prolapse in these patients. And do lab tests like urinary calcium, alkaline phosphatase, vitamin D, parathormone, bone scan, and an MRI or an X-ray of lumbar spine. You may notice that although we have written these tests, I have not mentioned serum calcium. That's because serum calcium is not a good marker of total body calcium. It's the urinary calcium. Even parathormone is a better indicator. Therefore, we did this and we did not do serum calcium. And what did we find? A compression fracture of the lumbar vertebra. And that is what may happen. In fact, if you look at the literature, you may find that there is a 1.4 times increased fracture risk after bariatric surgery in normal population. And secondary hyperparathyroidism, from sleeve to gastric bypass, it keeps on increasing. More the malabsorption, more the secondary hyperparathyroidism. And we must measure parathormone in these patients because, as I said, serum calcium is not a good marker. Urinary calcium is common to do, therefore most centers don't do it. But if you are not doing it, at least check the parathormone, vitamin D, bone scans, alkaline phosphatase to have an indirect idea about bone health in these patients. Having a fracture is a disaster in a bariatric patient. Although it's rare, it's something to be worried about. Strategy, give calcium citrate. Don't give everything in one go. Divide them throughout the day for better absorption in bariatric patients. Remember, they have been GI altered anatomy. Vitamin D needs to be given. patients need to do exercises. It's the exercise, the physical training, which improves bone health. And very few patients realize that. They think that their bone is weak, they don't want to exercise. It's just the reverse. Bone scans are important after 2 years to know about osteopenia. And finally, I've written bisphosphonates and canceled it to suggest that bisphosphonates are contraindicated in this setting. Case capsule, another case capsule. I must give credit to my senior colleague, Dr. Praveen Bhatia from Delhi. He shared this case capsule, very interesting. 35-year-old male, hypertension, had a sleeve gastrectomy 3 weeks back, and he presented with vomiting and dysphagia. He also had weakness, dribbling of saliva, confusion, and he was seeing double vision. What is this? This is some sort of a neuropathy. And this is how he looked. And this is how he was walking. And if you look at his gait, you can see that this gait is not normal. It's bottling. So differential diagnosis, hypertensive male boy. Can he have a stroke? Yes, he can have a stroke. Is it this vomiting is secondary to stenosis in a sleeve and then leading to thiamine deficiency, or directly a thiamine deficiency? Well, all of them are possible. MRI brain was normal. Gastroscopy revealed no stenosis, and the vitamin B1 was low normal. And therefore, he was put on intravenous thiamine. There's plenty of literature on vernix encephalopathy after sleeve gastrectomy and bypass. And it's important to know that the thiamine RDA is only 1 milligram per day. And when it is a therapeutic dose, it's 100 to 300 milligrams per day intravenous. So don't be scared. That is the dose that needs to be given to reverse a vernix encephalopathy. And therefore, this should be given till the patient recovers, and then the patient should be put on 100 milligram per day, oral thiamine on discharge. Don't worry about toxicity. B complexes are water-soluble vitamins. They do not have toxic effects. They are washed away out of the body. So that's very important. But there are other reasons for neuropathies. If you see a patient at 2 years or 3 years or 6 months or 3 months, all of them may have a different cause of neuropathy. Vernix is usually an early cause of neuropathy. But a mechanical neuropathy, because of posture and the way patient is positioned in the OT, can lead to a neuropathy, a foot drop as well. And there are certain inflammatory neuropathies, Guillain-Barré-like syndromes, which can happen after bariatric surgery, which we must be aware of, because if they are not treated early with steroids and admission, they can have permanent damage. And finally, nutritional causes of neuropathy like copper can happen in 3rd or 4th year onwards in a bypass patient especially. And therefore, one must be aware of measuring serum copper and assessing neuropathies at this time. Now, there are a huge list of what are important in neuropathy, but this is more or less the commonest causes or nutritional causes for neuropathies. Let's move on. A one anastomosis gastric bypass is a more malabsorptive procedure than a sleeve and a Roux-en-Y gastric bypass, less than a duodenal switch. So it is somewhere between the Roux-en-Y and the duodenal switch. And this patient, after operation, lost from 150 kg to 80 kg at 1 year. And I wasn't there at the center, and the nutritionist said, well, you're doing great. You lost 70 kgs in a year. But, you know, at 2.5 years, this gentleman came with severe weakness, unable to walk, oily stool, leg edema, severe pallor, and more than 100% excess body weight loss. Now, I must say here, the reason why this patient did not come for a year or so is because he had some personal problems in a different country and he was not allowed to move out. And imagine when we operate on our patients who come from different countries, if this happens and there's nobody to give bariatric nutritional follow-up, this is what patients can come up with. He came with that xiphoid protruding out. He had bad malnutrition. What lesson we learned is, as a nutritionist, as a surgeon, don't only see body weight, see body composition analysis. Look at fat mass, look at fat-free mass. If the muscle loss or the fat-free mass is more than 20% of the total weight loss, that's abnormal. So somebody's lost 50 kilos, but more than 10 kilos is muscle. Beware, this could be leading to cachexia, sarcopenia, or protein energy malnutrition. Beware. And this is the body composition analysis, which I always show, suggesting that whether surgeons are aware that how to interpret this. So that's for another day again. Now, treatment is you've got to admit this patient, can't go home. This patient has to be assessed. They have a low albumin, low hemoglobin, and that's 8.5. Actually, is after dehydration. It must be about 3 or 4. D is low, iron is low. They need to be hydrated, electrolyte correction, especially phosphates need to be given, taxol need to be given. They need to be on a parenteral nutrition, multivitamin infusions, and iron infusions as well. And these patients would first need a tube gastrostomy, as Dr. Arun Prasad said, and then they can have a reversal. Finally, alopecia after a sleeve gastrectomy. Very common after any bariatric procedure, one may see that there is an alopecia. The important thing to remember is this is telogen effluvium, where the patient's hairs are going into the stage of dormancy. What you need to do is tell them their hair follicles are still intact, they just gone into dormancy, they will come back, reassure them. But if these patients come with alopecia at 18 months, then there is no complacency. One has to look at compliance of the patient with supplements and check the albumin, iron, ferritin, zinc, folate, and essential fatty acids. And if these are abnormal, then they need to be replenished. Biotin is a hype, mostly in the pharma companies. There's little evidence, but maybe it does contribute to hair loss, but not as much as iron and zinc. So if you have to supplement, you must supplement them with good amount of iron and zinc. And it's important to understand, although we are not dermatologists, we need to understand that alopecias could be scarring and non-scarring. Some patients with alopecia already have a pre-existing psoriasis. These patients have a scarring alopecia. Now, those ones are different from the non-scarring alopecia seen in bariatric surgery. That has to be differentiated, A. 2, if it is a non-scarring alopecia, topical solutions like minoxidil may work. And nutrients which are appropriate needs to be given to these patients. Largely, it should be protein, iron, and zinc, and essential fatty acids. I would like to stop here because I think this is enough for a day. There are many things that can be discussed, but I'll rather spend time on discussion than going on. So the take-home message I would like to give from this talk is, no matter how beautiful a bariatric surgery you do, and no matter what procedure you do, what good is a good procedure if it does not lead to good outcome? Any center doing bariatric surgery will have to learn about bariatric nutrition if they want to have optimal results from the patient. Remember, nowadays we're talking about PROM, patient-reported outcome measures. And if we are talking about PROM, then PROM has to have a nutritional follow-up very diligently in our center. And that is what is going to mark the success of a bariatric center. Thank you very much. Aparna, back to you.
Thank you so much, Dr. Baig. I think that was a wonderful lecture. And I do agree with you that it can go on. It can be a whole session by itself. And I just have a couple of things that I would like you to comment on. And the first one is that most of these patients with obesity, they actually, though we think that they are overnourished, but they are actually very malnourished. And what is your take on that? And what is your take on optimization, nutritional optimization of patients before bariatric surgery? How long should we give it? How much? And so on.
So very important question. Obviously, for the paucity of time, I eliminated many things. One of that is this, that obese patients, when they come to us, they have a paradoxical malnutrition. And the paradoxical malnutrition is let's say for iron. I'll just give you an example. Iron deficiency is very common in obese people. Why? Because they have chronic inflammation. And because of chronic inflammation, there's high hepcidin, high CRP. What does hepcidin do? It sequesters the iron into the enterocytes and the macrophages. They don't get into the blood circulation. They're not utilized for erythropoiesis. So in effect, although this patient has a total high total body iron, but the blood iron is very low. And for erythropoiesis not available. Therefore, they have anemia. So imagine this is a paradoxical malnutrition. Similarly, vitamin D, it gets sequestered in the fat. And therefore, vitamin D is very low in these patients. Almost 80 to 90% of obese patients have low vitamin D. So we need to realize that these patients, although they may have high calorie intake, but either because of poor dietary choices or because of these biological reasons, they will have paradoxical malnutrition. So A, D, iron, these are malnutrition that you will see commonly in obese people with different reasons altogether.
Right. Thank you. And my second question is about checklists. I know that you follow, you're a great follower of checklists. And would you like to say something about that. There is a lot that needs to be looked into after bariatric surgery. So what is your recommendation to junior and senior surgeons, everybody? Because I think everybody should have these checklists. So what do you want to say about that?
I want to say that don't rely on your memory. It's very poor. Just accept it that your memory is very poor. Checklist by Atul Gawande is a great book to read. And once you read that, you realize that everything has to be written. So two things. Before the patient goes for bariatric surgery, there is a checklist, and two things are important in our center: nutritional clearance and psychological needs. If the psychologist doesn't clear the patient, we don't operate. If the nutrition doesn't clear, we don't operate. So that's part of the checklist, pre-operative. Post-operative, we have a history performer, a clinical examination performer, lab test performer, and that is written and everything is checked. I have it in my presentation. I could have shared it, but I think for the lack of time, that will not be done. But make your own performer where you have to write the details rather than investing in your memory. Just write those things down and everything in history. For example, I will just say, don't miss on body composition analysis. But if you don't write down, you'll miss it. And if you don't do body composition analysis, one may miss the malnutrition, the PEM with malabsorptive procedures. So I can just go on with various examples. I'm just going to say that have a pro forma for history for dieting, dietary history, psychological history, behaviors, everything on the paper so that you just keep on marking them.
Right. So I think a good follow-up, if it is done properly, it takes a minimum of 30 to 45 minutes per patient. And that is one of the issues with bariatric surgery, that follow-up OPD is huge and it takes very long. So my last question for your comment would be, what should be the ideal follow-up protocol? And do you think there is any difference between procedures and their follow-ups, or should it be uniform across bariatric procedures?
So I'm just going to quote the ASMBS guidelines. The guidelines say that for sleeve or bypass or any other bariatric procedure, it should be the same follow-up. Lab tests may differ. In a bypass, more malabsorptive procedures, one may do lab tests a little more stringently. You may add zinc and copper and fat-soluble vitamins as well. Whereas in a sleeve, you may like to omit them and do only if indicated. So that's the lab test difference. As far as intervals are concerned, it's the same. When it comes to supplementation, again, it's lifelong. It's not 1 year or 2 years or 3 years or 4 years, but it's lifelong. Lifelong supplementation, lifelong monitoring. But for a sleeve versus a bypass, one gives lesser dose of supplement compared to a bypass. So for example, 1 RDA of B2 will be enough for sleeve, but not for bypass. So one will have to understand that when you have these bariatric supplements, they will say you have to give 2 capsules in a day for a bypass, but 1 capsule in a day for or 1 tablet in a day for a sleep patient. So apart from these smaller differences, as far as follow-up intervals are concerned, as far as duration of supplementation is concerned, is the same.
Thank you so much. And I think, like I said, this topic could be an entire session in itself. But due to paucity of time, I think we really need to close this now. I would like to hand over the thing back to Dr. Agarwal and Dr. Sunil Popat. Thank you so much.
Thank you, Sarfaraz, for giving this lecture from your car and waiting for the dinner. We'll let you go for your much deserved dinner now. Thank you so much. Wonderful.
Thank you. Thank you so much, sir. Thank you very much.
Thank you, Dr. Aparna and Dr. Saf. It's been exciting to listen as ever, and you did more than justice for a speaker to speak about nutrition. We look forward to have you more on board for a future academics. And I thank Aparna ma'am for making it more lively and sharing her contribution towards the nutritional work as well. Thank you, ma'am, and thank you, sir. Now we move on to the next important session. Complication after complication, it becomes exciting way of learning. And I'm sure this is the most happening stuff which is happening in the endotherapy for bariatric procedures. For that, I have the honor of inviting our honorary secretary, Dr. S. Ishwarmurthy sir. Dr. Ishwarmurthy sir has 6 gold medals.
Agarwal, we lost your voice. Can we go ahead?
Hello, Ishwar. Good evening.
Yeah, I'll go. Yeah, good evening. Good evening.
Bringing in the
Agarwal, let me go. It's fine because people know me.
Let me introduce Ishwar. Ishwar, welcome. Honorary Secretary of IAGES for last 1.5 years, and very dynamic and basic laparoscopic and endoscopic surgeon. Ishwar will moderate the session on complication of ESG, endoscopic sleeve gastroplasty. Over to you, Ishwar.
Thank you. Thank you, President. Thank you, Agarwal, for this very entertaining prime time today. Dear viewers, right now I'm very, very pleased to have Dr. Mohit Bandari from Indo. He is one of the bariatric surgeon for excellence. As you all aware, he has done more than 15,000 bariatric procedures, and you go to Guinness book, Limca book, his name would be there. And I'm very, very nice to see as an endoscopic practitioner myself to see that he brought the endoscopic sleeve gastroplasty to India in 2017, and now he has established a world-class bariatric endoscopic unit, the go-to place to learn. So I always admire his hunger to learn and teach. And let us go without much ado to Dr. Mohit Bandari to share his pearls of wisdom on the ESG and its complication. What all the budding surgeons to learn from him. Over to you, sir. Yes, Mohit, we are with you.
Good afternoon, everybody. I am Dr. Mohit Bandari from India at Indore, and I am founder, director, and chief surgeon at Mohawk Bariatric and Robotic Surgery Center. First of all, big congratulations to the organizing committee, and I've been asked to speak about endoscopic sleeve gastroplasty complications. These are my disclosures. The important one is that I work for Apollo Endosurgery, Pentex and Olympus, and also Professor Galvao NATO is a director of bariatric endoscopy services at Mohawk Bariatric and Robotic Surgery Center here in India. And we are so proud and honored to have the world's most distinguished leader, Professor Galvao, on board with us here in India. Manuel helped to establish bariatric endoscopy in different parts of the world, and including India, where if bariatric endoscopy has arrived, it is because of Professor Manuel Galvao NATO. He recently joined our department, and he's trying to bring a lot of new things, trying to introduce a lot of new services like the pH manometry services, dedicated intragastric balloon program, the post-2, and obviously the endoscopic sleeve gastroplasty. So if we talk about our center, we are primarily a bariatric center, and we have done close to 15,000 bariatric procedures. If out of them you see around 600 plus have been the endoscopic sleeves. We all know that endoscopic bariatric procedures are basically a bridge gap between the medical therapy and the surgical therapy. But the surgical therapy has a steep learning curve. And also, if we see endoscopic suturing, it also has a steep learning curve. The only difference is that there we are breaching the abdominal wall, and here we are just doing an endoscopic method where there is nothing on the abdominal wall. There are different suture patterns of endoscopic sleeve, and we should all understand that it is not equivalent to sleeve gastrectomy in any way, because in sleeve gastrectomy, the gastric transit time is very less, and the food empties into the duodenum pretty fast, whereas the simple mechanism on which endoscopic sleeve gastroplasty is based is delaying the gastric emptying. So you can see that there is a very delayed gastric emptying, and this has been published by several others, including Abu Dhabi. That is how, if we see a particular endoscopic sleeve would look like. So this is a very beautiful video taken by Manuel Galvao. We did, both of us, me and Manuel, we did this case in Bangalore. And if you can see, this is the endoscopic picture. And parallelly, you would see the laparoscopic view of how the endoscopic sleeve looks. So pretty good, pretty tight. It looks like a sleeve gastrectomy. For the surgeons who are watching this, this was a cirrhotic male, keen only for endoscopic sleeve, and he lost already around 20 kgs. This is a very beautiful MR image. It's a dynamic image, and it is showing how the food empties after the endoscopic sleeve. So basically, in these many cases, we at our own center, we did couple of revisions. This is our data. Very impressive, 19 to 20% of total weight loss with good resolution of comorbidities. But yes, we have complications. So what are the complications for endoscopic sleeve? So this was published by my friend Gontran Lopez Nava and Reem Sharia, and they reported that the serious adverse effect events in the endoscopic sleeve is 2%. Perigastric inflammatory serous fluid collection can happen. The best management to treat it is percutaneous drainage. There can be submassive pulmonary embolism 72 hours after the procedure. And I think Manuel Galvao told me that they published the Brazilian consensus and they could publish that they had 1 death due to this procedure because of pulmonary embolism. Self-limited hemorrhage after splenic lacerations, it can obviously happen because you're taking those sutures close to the fundus and you can take a bite through it. Pneumoperitoneum and pneumothorax can obviously occur, and a tube placement or a surgical drainage can be one of the surgical treatment can be one of the options. If you see this particular study, the intra-abdominal collection 0.4%, hemorrhage requiring transfusion or endoscopic intervention 0.4%, refractory symptoms requiring the ESG reversal 0.2%, pneumoperitoneum and pneumothorax 0.1%, pulmonary embolism 0.1%. So we see it's a 1% rate of complication, much less than bariatric surgery. That's pretty significant. So this you can see is a hemorrhage from the line of the endoscopic sleeve. The hemorrhage can be pretty much radical, and these are the perigastric collections. And as you can see, this is shown on the CT scan. The contrast done 12-day post endoscopic sleeve, and you can see these kind of collections. These are not very uncommon. There can be gastric perforations. So you see, this is the perforation. It's very beautiful case report. So these things are common. So another case where you find a lot of bleeding, specifically after endoscopic sleeve. This is a case where we had one of the colleagues who shared this video. They shared that there was a leak after endoscopic sleeve. So this is common. Biliary peritonitis after endoscopic sleeve is also reported. And this particular study published by Gontran Lopez Nava in Gastrointestinal Endoscopy shows that you can take a bite through the gallbladder and perforate it. And that's common. Talking about the conversions, the beautiful thing with this procedure is that you can do both sleeve gastrectomy and Roux-en-Y gastric bypass after both of these procedures. So people say that it's very difficult to convert. No, it's a very simple procedure to convert. And as you can see, these are peak cinches, and this procedure failed. And this is the endoscopy. This is the laparoscopic sleeve done at our center. Very easily we could do a banded sleeve, and then you can see this endoscopy and beautiful area. This is one of the area where we got a proline suture which got into our stapler. We cut it and we could complete the procedure. So at this point of time, we are managing most of these complications. But what I would say, nausea, vomiting, epigastric pain, and reflux and dehydration remain the most common complication. I already discussed about bleeding, stomach leaks, blood clots, and pulmonary embolism, stenosis. If you try and go very close to the lesser curvature of the stomach, the esophageal injuries are common if you try and use a double lumen scope without an overtube. And these complications are also accompanied by 5 to 8% of patients who do not have significant weight loss, or they have weight regain. We don't call them necessarily complications, but poor outcomes after endoscopic sleeve. And obviously a revision ESG or conversion to surgical revisions or concomitant usage of drug and physical therapy are good thing. This is our Mohawk data. We had absolutely no bleeding, no blood clots, no stenosis. God forbidden, we never had God willing, we never had bad complications like esophageal injuries or injury to the gallbladder or anything like that. But yes, we had very high incidence of nausea and vomiting. We had 1 to 2% incidence of esophagogastric pain and reflux, and some dehydrations. So to conclude, my friends, endoscopic sleeve has minimal complications, much less than bariatric surgery. It is very effective procedure, and after doing this large series of more than 600 cases, it still finds a very important place in the algorithm which we use to treat. All we need to do, as Professor Phoebe says, is to maintain a data in a prospectively maintained database, keep assessing it over a regular period of time, and then after sometimes you would realize how you can change your practice in the light of that particular prospectively maintained database. Thank you very much, ladies and gentlemen.
Thank you, Dr. Mohit. It was wonderful to have your very concise and confident presentation, and very open to all the problems one can foresee. Just for the benefit of all the youngsters who are watching from India, we want to know whether is it a procedure on evolution or a technique under evolution, or you think it has a bright future in the Indian population? What's your view on that? Mohit, can you take this question? Over to Mohit.
Mohit, Ishwar, that lecture was recorded earlier few hours ago. Okay. As he was traveling and he was to connect from the airport. I don't know. Nitin, has he connected?
Sir, I think he's still in the mute. Right.
I think we can conclude in the way.
Probably, yeah.
Ishwar sir, please go ahead with the time.
Yeah, I think from what I can see from the literature, I think from the vast experience and the interest on this procedure, and the Apollo overseas based on which this procedure has been done, apart from the ESG, it has other extended indication, the equipment itself. And once people pass through the learning curve, I think it has a potential. Initially, there was some skepticism because we are not removing the fundus. Now, Mohit has clearly explained. It is the delayed gastric emptying, which is a real basis, is not in the gut hormonal changes that is making the difference of weight loss. And the thing is, I'm sure it is a few years down the line, we'll know that even though the results, the efficacy may be slightly inferior to the lab sleeve, I'm sure the indications are going to be more defined, and the technique is going to be more refined. I'm sure sooner or later it is going to find its place once we prove the efficacy and also cost effectiveness in our Indian population. So with that, I think we'll conclude the talk. If there is any questions in the YouTube channel or anything else, Kanagavel, please come over. Otherwise, we'll conclude the session because it's now close to 11 o'clock.
Yeah, I think we need to conclude now. We have had a wonderful session, Ishwar. Thank you. And we had a very interesting thing that several of our speakers were giving lecture while traveling. Sarfaraz gave from his car. Our convener, Dr. Kanagwal, was moderating from the car himself. And Mohit was actually traveling from one airport to another airport. So that's the beauty of this digital world. And overall, we had a very successful program. So I would request Kanagwal to take it forward.
Thank you, President. Thank you, all the speakers. I will have the honor of inviting our Honorary Secretary, to propose the vote of thanks.
Thank you. Can you see my slides, Kanagwal? I'll quickly.
Yes, sir. Yes, sir.
Very short and sweet. Okay, thank you very much. Thank you. I think we need to thank our president and also Kanagwal having brought this 3 hours. I think literally we had 3 hours of this marathon on the bariatrics with the 5 masters in this episode of Prime Time. Thanks to all of you. I think we had a wonderful discussion on various complications on the common bariatric procedures. And I really thank all our moderators who stayed and interacted with all the speakers, and our heartfelt appreciation to Dr. Sandeep Agarwal, Dr. Rajesh Kullar, Dr. Arun Prasad, Dr. Sarfaraz Baig, and Dr. Mohit Bandari. We have already sent them all the certificate of appreciation as they spoke, and our appreciations to them and also the moderators. And quickly to come to some important news for the benefit of all our new members. As you all know, we had a very interesting, exciting intercontinental webinar last month. And from there on, we moved from the online mode to the on-site with the COVID fading, and with the Kanagwal hosting a twin treat of EFAGS and FAGS, the basic endoscopy laparoscopic program, with the first time cadaver program. It was a huge success with close to 200 delegates participating. We can see the happy faces, fellowship and friends up. And this is the first time this year we also had the Tamil Nadu Medical Council credit points for both the courses. And we can see a glimpse of our treasurer doing the first cadaver endoscopic program also. And there also we had the mobile app. I want all the members to go and upload this, whether you have an Apple phone or Android phone, you can have this, and all the updated programs and everything will be in touch of your button away. And the next month in October, this month, later this month, the 22nd to 24th, we'll be back in Chennai in Gem Hospital under Praveen Raj for this colorectal. Please join this course. I'm sure it will be a very exciting one. And if you keep watching, we are going to be very vibrant with more academic coming with the Goa in November 19th to 21st. Watch the calendar. People who have done on-site program, it's an online program who wants to come for assessment. This is the next place where they can come. So please contact Dr. Gb Oagb, who is a course convener and coordinator for this. And December is going to be a hectic week, not only for you, for all of us in the EC, because we'll be traveling almost all weekends with the falls bariatric, hernia, robotic, and Haji from one corner of our country to the other corner. Finally settling down to Trichy for a twin program in January, and then Trivandrum, and then finally we all want to invite you all to Rajamundry in 10th to 13th February for a grand gala fellowship convocation and also an excellent conference, pre-conference masterclass. All because of the dynamism of our president and all our EC. We thank them all, and we also want to tell all our academicians like postgraduates and also the young IAGES members about our academic initiatives. If you are interested, please write to us for a Best Postgraduate Thesis Award. The links will be available on request to me as IAGESacademic.gmail.com, and also the IAGES Best Researcher Award. And there are 5 awards in each category worth not only 1 lakh cash reward, also a certificate of appreciation during our convocation. So more to see, everything you'll find out either in the IAGES Connect or in the mobile app. Until then, we thank Kanagavel, Professor Sunil Popat, the whole Doc Plexus team for a seamless transmission, and a good night. Bye-bye now.
Thank you, Ishwar. Thank you, everybody.
Good night, President. Good night, Secretary Sir. Good night, Doc Plexus team, and all the friends who are connected at various platforms of IAGES. Good night, everyone.
Good night, sir. Good night, sir. Have a good night. Take care.